Special Joint Committee on Medical Assistance in Dying. I'd like to begin by welcoming members of the committee and all our witnesses, as well as those watching on the web. My name is Jana Martin, and I'm the Senate's Joint Chair of this committee. I'm joined by Renee Arsenault, the House of Commons Joint Chair of the committee. And today we continue our examination of the degree of preparedness attained for a safe and adequate application of medical assistance in dying where mental disorder is the sole underlying medical condition, in accordance with Recommendation 13 of the committee's second report. I want to remind members and witnesses to keep microphones muted unless recognized by one of the joint chairs. And as a reminder, all comments should be addressed through the joint chairs. When speaking, please speak slowly and clearly. And for those appearing by video conference, interpretation is available. You have the choice at the bottom of your screen of either floor, English, or French. And with that, I wish to welcome our witnesses this evening. Thank you very much for your presence. As individuals, Jocelyn Downey, Professor Emeritus at the Health Law Institute at Dalhousie University's Shurlitz School of Law. And Trudeau Lemons, Professor and Scholl Chair in Health Law and Policy at the University of Toronto's Faculty of Law by video conference. From Health Canada's Strategic Policy Branch, we have Jocelyn Voisin, Assistant Deputy Minister, and accompanied by two officials with the Healthcare Programs and Policy Directorate, Sharon Harper, Director General, and Jackie Lemaire, Senior Policy Advisor, and from the Department of Justice Canada, Miriam Wills, Counsel, Criminal Law Policy Section.
J'osais pas vous interrompre, Madame la.
Sorry to interrupt you, but unfortunately we always have the same problem at the start of a meeting. The sound in the room, the volume is far too loud compared to over Zoom. So if I want to avoid having too loud a volume in my ears, that volume needs to be adjusted. This needs to be done at the beginning of every meeting. As just like we do the remote testing of the sound, we need to test the room sound. I'm really sorry to have to interrupt you at each and every meeting. It's going to continue to be like this if we don't nip this problem in the bud. So again, I'm sorry, but c'est la vie.
I'm assuming the sound is being adjusted.
Faudrait que vous parliez.
Well, you'll have to speak a little bit so we can test as we go along, please. And that way we'll be able to recalibrate the sound.
A list of witnesses and the order, and as I'm speaking, hopefully they're adjusting the sound. So let me just do that, and then I'll wait before we have our first witness. Okay. Oh, it's okay. Okay, very good. Thank you, and thank you for that reminder. We will begin with opening remarks of 5 minutes by each of our witnesses, Professor Downey, followed by Professor Lemons, and then the federal official, Ms. Voisin. So, Professor Downey, the floor is yours for 5 minutes.
Good evening. Thank you for the invitation to speak with you. My name is Jocelyn Downey, and I'm a Professor Emeritus in the Faculties of Law and Medicine at Dalhousie University. I've been honored to be made a Fellow of the Royal Society of Canada and the Canadian Academy of Health Sciences, and to be named to the Order of Canada for my work on this topic. I start tonight with the committee mandate to verify the degree of preparedness attained for a safe and adequate application of MAID in MDS-UMC situations, with particular reference to standards of practice referred to by the expert panel. On this metric, preparedness has already been established through your hearings. You know that the Model Practice Standard was published in March 2023 and have received uncontroverted evidence that the professional regulatory bodies are ready. However, in case you go beyond this mandate and/or adjust the metrics, more needs to be said. First, the Charter. A barrier to access to MAID based on a diagnosis with a mental disorder is a limit on the Sections 7 and 15 rights of persons with mental disorders. The arguments for this can be found in the testimony of numerous witnesses, briefs, and legal decisions. A purported lack of preparedness might be presented as an attempted justification for the limits on the rights under Section 1. However, that argument would fail. The federal government is prepared. It has amended its reporting regulations, created an independent expert panel on MAID and mental illness, created an independent expert task group to draft a model practice standard, funded the independent national accredited curriculum to train MAID assessors and providers, and supported a knowledge exchange workshop that brought together MAID assessors and providers and psychiatrists from every jurisdiction in Canada to prepare together for the implementation of MAID MDSUMC. Furthermore, the very people tasked with regulating the conduct of MAID assessors and providers have confirmed for you that they are prepared. Clinical preparedness has been established through the delivery of multiple training sessions across the country, the existence of a community of practice among expert psychiatrists coast to coast, the experience that MAID assessors and providers already have with assessing MAID requests from persons with mental disorders, the experience that psychiatrists already have with acting as consultants for both tracks 1 and 2 patients, and the development of protocols and policies at the programmatic level. Any lack of political preparedness is not a justification for limiting charter rights. Any purported lack of clinical preparedness by some psychiatrists is not a justification for limiting charter rights. Not all clinicians in Canada were prepared for MAID when it first came in. Any individual psychiatrist who does not feel prepared is under no obligation to participate in MAID. And it is abundantly clear that psychiatrists from across the country, including eminent psychiatrists, eminent experts in psychiatry, are prepared. Some might say that not all Canadians are prepared. However, not all Canadians were prepared for MAID. Furthermore, no person is ever compelled to get MAID. The protection of charter rights does not and cannot wait for some subset of the public to be prepared. A preparedness claim, therefore, cannot serve to save the limits on charter rights that any further delay would entail. Now turning to the division of powers under Section 91 and 92 of the Constitution Act. The federal parliament must approach the issue of preparedness with attention to its own jurisdiction, and it is abundantly clear that it is prepared. Even if you aren't persuaded that all of the provinces and territories are ready, a counterfactual, given the unequivocal evidence from the provincial territorial regulatory colleges, as well as information available about MAID programs and PT oversight mechanisms, the division of powers dictates that you not delay further. Look to history. Consider, for example, the 1969 Act that made abortion legal under certain conditions. The Act was passed in May 1969. Royal assent given June 69. The abortion provisions came into force August 69. Parliament didn't wait for the newly required therapeutic abortion committees to be established in hospitals across the country. The federal parliament made the changes it felt were right to protect women's rights and left it to the provinces and territories to do that which was necessary to implement the changes at their level. There's also a logical and ethical basis for this view of preparedness. If the federal parliament were ever to tie the changes to the criminal code to provincial territorial preparedness, it would be allowing the provinces and territories to subvert the federal parliament's decisions with respect to the criminal law. It would also be allowing any laggard provinces and territories to hold hostage those other provinces and territories that got ready. It would allow the protections of charter rights of people in the provinces and territories that got ready to be blocked by those provinces and territories that chose not to be ready. This is something the federal parliament should not be a part of. I leave you with one final thought. The trial decision in Carter was released in 2012. Truchon was decided in 2019. Bill C-7 was passed in 2021. It is now 2023. A further delay would take us to 2025. Justice delayed is justice denied. Thank you.
And we will now go to Professor Lemons. You have the floor for 5 minutes.
Cher Président, members,
Chairs, members of the committee.
is to protect the life and promote the well-being of Canadians. Expanding MAID to include it for reasons of mental illness is an unprecedented threat to that. It appears driven by 1, a flawed claim of perception of constitutional obligation, 2, a strong prior commitment to expansive MAID by a core group of people with dominant input in the policy process, who overwhelmingly emphasize the need for access, not protection, and 3, a lack of appreciation of how problems in jurisdictions that allow it will even be more serious here because of weaker legal standards. First, there is no constitutional requirement to introduce death to solve often severe suffering from mental illness. This is emphasized in a letter to Cabinet by 31 Canadian law professors, including constitutional and human rights scholars, in several academic publications, including a forthcoming article, and in committee submissions by law scholars in the Vulnerable Person Standard. These also clarify why it is not discriminatory to limit access to MAID. No court, definitely not the Supreme Court, has ruled that death induced by physicians is an inherently or predominantly beneficial procedure to whom all must have access as a right. It is a complex practice which the court ruled should be permitted in exceptional circumstances as a carefully crafted exemption to a crucial criminal code prohibition. In fact, the opposite is true. Singling out disabled persons, soon also persons with mental illness whose disease cannot be determined to be irremediable, exposes disabled persons already subject to systemic discrimination to a serious risk of death. This also threatens their right to life. It attaches the highest possible discriminatory stigma to what it means to have mental illness and to be disabled, namely that our system offers them death rather than sufficient support while it continues to protect others. Second, before this committee, some medical experts insist we need to offer MAID for mental illness as a, quote, constitutional right, while they hesitate when asked whether we can do so safely and whether irremediability can be determined in individual cases. That, I would put forward, is a caricature of how cautious policy and lawmaking should work. Medical policy and ethics experts must inform government, MPs, and the courts what MAID expansion will mean. With Canada's MAID policy, this has been turned upside down. Parroting constitutional rights rhetoric, government has given some with a prior vested commitment privileged positions to implement it. It is striking that those who now reassure us that concerns are unwarranted claimed from day one that MAID for mental illness was unproblematic and should not be treated differently. Yet they were given authority to evaluate if other safeguards were needed, then failed to recommend them, which leaves it up to the discretion of individual professionals whether people will live or die. Authorities didn't even reach out to the broader mental health community when a patient advocate and bioethicist resigned in protest from the expert panel on MAID for mental illness. It is further troubling, as one submission highlights, that some of the same experts recently provided misleading information to MPs when the recent bill aimed at halting this expansion went up for vote in Parliament. 3, the claim that we only need a few psychiatrists willing to do this because few patients will qualify is wrong. And instead of reassuring, it is concerning. First, in Belgium and the Netherlands, the practice remains controversial, in part because a few psychiatrists have driven the practice in problematic directions. A criminal prosecution temporarily stalled expansion in Belgium, where one psychiatrist was involved in nearly half of the mental health euthanasia cases from 2007 to 2011. In those countries, physicians must agree that there are no other options left. Approval rates for psychiatric euthanasia are low, 5 to 10%, mostly because of irremediability. But when euthanasia for mental illness becomes more broadly practiced, demand for it increases steeply, from 500 in 2008 to 1,100 in 2015. Demand in Canada will be higher and no legal constraint will keep the approvals low. When regulators state that they are ready, we need to ask for what? Yes, there will be flimsy regulations, which rules that leave so much discretion that there will be little basis for criminal prosecution or professional discipline. Our law and professional rules will offer a largely open-ended license to end the lives of mentally ill patients. This is an egregious form of discriminatory abandonment of mentally ill Canadians and their families. I urge you not to hide behind the rhetoric of a constitutional right to let this expansion go forward. Je vous implore de ne pas vous cacher sous le couvert.
I implore you, do not hide behind a constitutional right to allow this expansion of the legislation.
Thank you very much, Professor. Lastly, I understand you're sharing the 5 minutes, so Ms. Voisin and Ms. Wills, is that correct? No, just... Okay. I see. I had a note here about that. All right, so you have the floor for 5 minutes, Ms. Voisin.
Okay, thank you, merci. Thank you, chairs and members, and for inviting us here today. And I want to thank the committee for their work and commitment on this issue so far and continuing. J'aimerais commencer par dire que
I'd like to start out by saying that Health Canada believes that Canadians deserve to live in comfort and dignity with access to care, including end-of-life care, that is appropriate to their needs and that respects their wishes.
That MAID is a deeply personal choice and are committed to ensuring our laws reflect Canadians' evolving needs, protect those who may be vulnerable, and support autonomy and freedom of choice. The Federal Criminal Code of Canada permits MAID to take place only under very specific circumstances and rules, as you know. Anyone requesting MAID must meet stringent eligibility criteria to receive MAID medical assistance in dying, and any medical practitioner who administers an assisted death to someone must satisfy all the safeguards first. Compte tenu de votre mandat, je comprends que vous vous concentrez.
Given your mandate, I appreciate that your focus is on the system preparedness of the system to offer MAID for persons with mental illness as the sole underlying condition.
To prepare for the lifting of the exclusion for MAID eligibility for persons suffering solely from mental illness, Health Canada has been working closely with provinces and territories, as well as stakeholders in the mental health sector, health professional associations, and others to address the recommendations of this committee on a companion document, which is the advice to the profession. We also funded the Canadian Association of MAID Assessors and Providers, so CAMAP, to develop and deliver a nationally accredited bilingual MAID curriculum. Registration continues to grow, with at last count of 901 registrants as of November 17th, and of these, 490 are physicians, 132 are psychiatrists, and 279 are nurse practitioners. The curriculum includes 7 modules, including a module on mental illness as the sole underlying condition. We also have enhanced our existing data collection on MAID through the federal monitoring system to help determine the presence of any inequalities or disadvantages in requests for the delivery of MAID. And we continue to engage with Indigenous peoples as requested and recommended by this committee through both an Indigenous-led and government-led activities, which will culminate in a What We Heard report in 2025. And finally, to support case review and oversight, we are working with the provinces and territories to enhance consistency and opportunities to share best practices on oversight mechanisms that exist in those jurisdictions. Ces ressources apporteront un soutien accru pour
These resources will provide enhanced support for both the assessment and provision of MAID in situations where death is not reasonably foreseeable, for example in cases of Parkinson's disease, as well as in situations where the request is made on the basis of a mental illness alone. At the federal level, we've been working diligently to ensure that tools and resources are in place to support clinicians and regulators in advance of March 2024. I know from my engagement with my provincial and territorial colleagues that they are working hard to prepare their health systems in the lead up to the lifting of the restriction. Many MAID assessors are already dealing with Track 2 cases where death is not reasonably foreseeable, which includes people who may have mental illness combined with other conditions.
The level of preparedness does vary across the country, and some provinces and territories have noted concerns, most notably with regard to ensuring enough trained professionals, especially with mental health expertise, and for assessment of Track 2 cases. Practitioners have told us that these requests are generally more complex and challenging because of the complexity of the conditions involved in the application of existing rigorous eligibility criteria and procedural safeguards. This means that clinicians assessing MAID are spending much more time gathering the necessary information about the person and their condition. The process often involves a review of many years of treatments, surgeries, and/or medications, and consultations with experts in order to exercise due diligence and make a decision about eligibility. The typical underlying medical conditions cited in Track 2 are neurological diseases, such as Parkinson's disease or multiple sclerosis. We know from the latest annual report in 2022, Track 2 cases made up only a very small proportion of MAID requests. There were 463 MAID provisions under Track 2, which represented 3.5% of the total number of MAID provisions and less than 0.2% of all deaths in Canada. In 2022, 2021, a partial year, 223 individuals with Track 2 requests received MAID, representing only 0.07 of all deaths in Canada. Encore une fois, je tiens à souligner l'importance du travail accompli.
Again, I want to recognise the important work done by this committee to date.
Valuable insights into the views of various stakeholders and federal officials have worked closely with provinces and territories and key stakeholders in the MAID community to continue to use these recommendations to support the improvements and the delivery of MAID across Canada. Merci beaucoup. Thank you.
Thank you very much. We'll go into the first round of questions from the members of Parliament, beginning with Mr. Fast for 5 minutes.
Thank you, Madam Chair, and my questions will be directed to Professor Lemons. Professor, today you've heard again here at committee the suggestion that the law in Canada compels parliamentarians to introduce MAID for the mentally ill. We heard that also from Ms. Shelley Birnbaum at our last meeting. She said she represented the CBA, the Canadian Bar Association, and she suggested that there was a strong charter of vulnerability if Canada did not expand MAID to include the mentally ill. Do you agree with that assessment, that we face a strong charter of vulnerability if we don't expand MAID?
I fundamentally disagree, and I'm not the only one who disagrees with that. I think many legal scholars, many people in the legal profession disagree. I think it reflects a distorted view of MAID as a quasi-inherently beneficial practice, and as if not having facilitated access within the medical system to it is a greater harm than death. So I think a discriminatory analysis, on the contrary, would focus on existing structural discriminations of persons with disability, particularly what persons with mental illness already face, at intersecting components, the higher risk to women, Indigenous persons, and persons living in poverty. And so I would argue, on the contrary, that adding easier access to death to existing grounds or existing inequality, while we continue to protect others against premature death, because we have to emphasize that. It's still in the criminal code. It still protects others, but we will now exclude that.
I want to be very specific. Is there anything in Carter or Truchon or in that Alberta EF decision that would compel Parliament to offer MAID to the mentally ill?
I urge parliamentary committee members to look at the submissions that you received. We submitted something. I think there is nothing in Carter, certainly not in Carter, that explicitly states that we have to legalize it. In fact, the Supreme Court explicitly excluded mental illness from its reasons.
Are there sufficient legal and procedural safeguards in place to safely implement MAID for the mentally ill?
In my view, there are not. So I think the safeguards that we have are easily circumvented. They are already circumvented in the context of Track 2. I would urge committee members to watch, for example, the recent documentary where we see, by Al Jazeera, where we see Rosina Kamis receiving MAID in the context of Track 2. In my view, it shows actually that you can drive a truck through some of the requirements that are supposedly protecting people from receiving Track 2 MAID. And I look at the practice guidelines, at the CAMAB educational documents that have been prepared, at the model practice standard, and at the guidelines. I see an overwhelming emphasis on the need to provide access to MAID, even to such extent that, for example, in the CAMAB documents, there is an explanation how you can easily turn track 1 MAID into a track 2 MAID into a track 1 MAID. In other words, even if you're assessed under track 2, for example, the CAMAB document states specifically that by refusing antibiotics for a serious infection, you can actually turn your track 2 into track 1. I would say that's for me symbolic of the way in which our regulatory approach has been in the context of track 2, and this will apply to the context of mental illness.
In your brief, you said, and I'm quoting, fresh constitutional analysis is indicated and a higher degree of deference is owed. What do you mean by a higher degree of deference?
Very briefly, Professor Lemons.
Well, I think this is very well established by leading constitutional scholars. I would refer here even to the statements by the late Professor Hogg, who explicitly actually changed his opinion and indicated in a more recent publication that basically Parliament was giving leeway to develop a detailed regulatory regime, and the courts have to assess that regulatory regime, respect the lawmaking by Parliament under a strict separation of powers.
Thank you, Professor. Next, we'll go to Mr. Scarpellegia for 5 minutes.
Thank you very much. This is very humbling to be, with this committee, many of which members were on the committee before and know much more about this than I do, and the witnesses, of course, are so incredibly qualified. Just by way of background, I'm trying to go back to 2 years ago when the Senate amended C7, I think it was, to remove the mental illness prohibition. When it sent the legislation back, did it add the need for an expert committee, or did the government add that? I should probably know that myself, but it's been a couple of years.
There's a committee review is embedded in the legislation.
It was embedded in the Senate amendment?
I'm not sure it came from the Senate or whether it was in the original bill, but it was certainly in C7.
Yes, it was, but I'm thinking maybe the government put that in, and the Senate just, carved out the prohibition.
Government.
Yeah, so the Senate sent it back without any kind of safeguard process in their amendment. That's interesting. But anyway, I'd like to talk about the issue of irremediability. Now, that's central because this is what sort of defines, in a way, as I understand it, why MAID is allowed, because something is grievous and irremediable. But when it comes to severe mental illness, there seems to be a lot of uncertainty around whether one can determine if a condition is irremediable. And I'm sure you've read the Globe and Mail editorial of last month, I think it was, where they cited, I'll just quote, one prominent study found that trained and experienced clinicians correctly predicted a patient's chance of long-term recovery in just 47% of cases, fewer than if they had simply flipped a coin. Could the lack of certainty around irremediability become a justifiable, like, Section 1 defense? Yes, please. Yeah.
No, I don't believe so.
Okay.
I think that one thing we have to pay close attention to is the fact that grievous and irremediable is in the law. It's not a clinical term. And serious and incurable illness, disease, or disability is in the law. And it is, in fact, a part of the definition of irremediability. So when people talk about not having a clinical definition, that's inappropriate, because we're not looking for a clinical definition of a legal term. Legal terms from the statutes should be defined in the statutes, and it is. And then what happens is the clinicians have to figure out, they determine whether that definition is met, and that's where you develop practice standards, and that's what we have. In the model practice standard, there's a clear statement about serious and incurable illness and so on, and so you wouldn't be able to show that it was missing. The other thing I'd add is, of course, natural death has become reasonably foreseeable is in the criminal code, and there isn't consensus amongst clinicians, there certainly wasn't when it first came out, about what it meant. So it's not a justification for violating the rights.
They make the argument here in the editorial that when it comes to, an illness like cancer, it's true, foreseeability is not 100% certain, but much more so than in the case of mental illness. But going back to the point you raised about the definition of irremediability in law, could you explain the difference then between that definition and the notion of irremediability in the clinician's opinion?
So one thing the clinicians will tell you is that the term irremediable is just foreign to them. That's not even a clinical term. They do recognize incurable. But when you have certain kinds of conditions, and it's not just mental disorders, the conventional understanding of incurable, there is no cure, is not available. So the lack of clarity around or consensus around what does incurable mean is not specific to mental disorders. So again, it doesn't work as a justification for singling out mental disorders. The other thing I would say is in relation to that Globe editorial is a group of psychiatrists have published a response to it because it was full of misinformation. And so I would invite the committee to review that response.
Okay, well, that's interesting. No, I mean, it's
Okay, there's 15 seconds remaining.
that's it? How much?
10 seconds now.
Well,
yes.
I don't think I have time to weave an argument or any kind of, a cogent question, so I'll let it go.
Thank you very much. So next we'll go to Monsieur Thériault for 5 minutes.
Merci, Madame la
Thank you, Madam Chairperson. It's difficult for me to follow the interpretation when I have colleagues that are making side comments aloud. So I'd call on my colleagues to be a little bit more quiet, a little bit more serene. We are talking about medical assistance in dying, after all. Dr. Downey, you previously sent us a text in which you stated that Carter and Baudouin did not exclude mental disorders or illnesses. Could you please refresh our memory in that regard? And why is that the case? We heard earlier that mental disorders were not permitted under Carter, and you said at the time in your statement that in Baudouin, the general exclusion based on belonging to a group was denied, such as vulnerable persons belonging to the vulnerable persons group. I'm not sure if you recall that, but could you please elaborate and explain how, for example, Carter, well, if you were to open things up to mental disorders, it would, by its very virtue, be unconstitutional.
So I think the key is to look back at Carter and recognize that the declaration was that if you create a barrier to access for people who have a grievous and irremediable medical condition causing enduring and intolerable suffering, that is unconstitutional. They did not say that mental disorders are not a part of grievous and irremediable medical conditions. They did not exclude them. They could have. They would have had they wanted to. That's the analysis. Mental disorders are a grievous and irremediable medical condition, and therefore it would be against the Carter Declaration if you had a barrier to access to people with mental disorders. The other thing, it is worth looking at the decision. I knew this issue would come up today because it always does. The EF decision is very clear. As can be seen in Carter 2015, the issue of whether psychiatric conditions should be excluded from the Declaration of Invalidity was squarely before the court. Nevertheless, the court declined to make an express exclusion as part of its carefully crafted criteria. So you have a circle, and it didn't carve it out. The other thing I guess would just add is we also have the G decision, which is important for us to remember from the Supreme Court of Canada now. It helps us here, I think, because it shows that what you have to do, you can't do a group-based exclusion. You must do case-by-case assessment. So there's nobody saying that there aren't some complex cases, but we have to do case-by-case.
Merci.
Sorry.
Bon. Évaluation au cas par cas.
Thank you. Case-by-case assessment. Ms. Scarpaleggia raised the clinical differences between cancer and the foreseeability of a mental disorder, for example. Now, earlier you raised the issue of experts' reports. Now, in that experts' report, aren't there any additional parts of a framework that would regulate opening this up to mental disorders? For example, the obligation for early monitoring that we can't find anywhere in Canada when it comes to implementing MAID. It's retrospective. And, for example, the obligation to have a second independent psychiatrist who's not part of the care team. Aren't there any yardsticks there? I'd like you to speak to those yardsticks, moreover. This is going to go to the Supreme Court, in my mind, and the court will determine whether opening things up this way is reasonable or not, and on the basis of right criteria, and what safeguards there should be, etc., etc. So that we don't fall into this slippery slope. So what are the arguments or safeguards that we find in this expert report, in your opinion, that would allow us to open things up to mental disorder in a safe manner?
40 seconds.
40 seconds. Okay. I think I'd actually answer with structure, a structural point, which is we have the criminal code, and then we have the colleges of physicians and surgeons and colleges of nurses. We have practice standards. And you should not get into the weeds of the kinds of things like which specialist do you need to see as your third person in your criminal code. That's not how the criminal code works. It should be in practice standards, and that's what's in those practice standards is advice about how do you do bringing up MAID, when should you have to see a consultant, should the consultant have to be a psychiatrist? And we actually took the position it shouldn't have to, because in fact it might be a specialist in something else that's more relevant. So it's a structural response, which is the safeguards are appropriate in the criminal code now. As we build out the protections, they are in the practice standards, and then they become in clinical protocols.
Thank you very much. And next we'll go to Mr. McGregor for 5 minutes.
Thank you very much, Madam Co-Chair, and thank you to all of our witnesses for helping guide our committee through this. It's not an easy subject, and I say that with experience of having been on this committee from the get-go, both in the last Parliament and this one. Dr. Downey, I'd like to start with you. You know, I'll freely admit that personally for me, I do have a level of discomfort when we're talking about mental disorders and access to MAID. And I'll tell you why. And before I tell you why, I mean, I also appreciate that our committee's mandate is quite narrow. We're not tasked with relitigating the law. In fact, the House of Commons just had a vote on that, and so you know we have to respect that process. But when we're being tasked as a committee with verifying the degree of preparedness, and I did listen to your open remarks, I'll tell you why I have a level of discomfort. You know, I represent the riding of Couch and Malahat Langford out on Vancouver Island. And I walk around my communities, and it is quite obvious that there is a mental health crisis going on. And, you know, you can see people who are in obvious need of help who are not getting the services that they require. And it's tearing parts of my community apart. So I guess, how do I, as a parliamentarian, a member of this committee, but also as someone who, you know, is trying to do right by his constituents, how do I verify the degree of preparedness? How do I satisfy that when I got that reality back at home?
So I think one of the things to do is make sure that those lack of supports and services are not driving requests for MAID, and they are not. We have good, solid evidence from the other jurisdictions, other permissive jurisdictions over the years, and we now have good data from Canada as well that that's not what's driving requests for MAID. Then what you do is you say, okay, both of these things are incredibly important. We need to protect the rights that the Supreme Court of Canada acknowledged and set out parameters in Carter, and we need to parallel promote supports and services for people with mental disorders, all the various things that bring about socioeconomic vulnerability. Parliament has an obligation to do those two things at the same time. Don't hold individuals' rights hostage to Parliament's failure to promote mental health supports and services, disability supports and services. Do them both. I think that's your responsibility, is to do both at the same time. And to know, and when you're answering back to your constituents, is to be able to tell them that these are not the drivers of MAID. People who are getting MAID are actually very, very privileged. They're white. They're well off. They're highly educated. They're not in institutions. They have families. So the picture of it is one of privilege. And so it doesn't mean we don't want to look after the people who are vulnerable. Sorry.
Thank you. I just got a couple of minutes left.
Sorry about that.
Ms. Watson, I'd like to turn to you. You know, my riding has a very high Indigenous population. Many of the elders are living with their past experiences at residential schools. And again, the level of supports in that community leave a lot to be desired. I know that Health Canada has been engaging with Indigenous peoples on MAID. Has the subject of mental disorders been a part of that? And is there anything that you can report to this committee based on that process?
Yeah, so in terms of our Indigenous engagement on MAID, we have been specifically engaging with those communities on a distinction-based approach. So we have an online survey, and we also have provided funding to some organizations to engage with their communities directly. And what we're hearing so far is that it's really important to take the cultural context into play when they're talking about MAID. And
sorry to interrupt, but on the specifics of a mental disorder or accessing MAID, has that been a part of the? That's what I want to focus on.
So I don't think that we have any. A few people have raised, the issue of mental illness in the context of MAID, but it hasn't. The consultation has been broader than that. It hasn't been focused on this issue specifically. So we don't have, a large amount of data to provide on how Indigenous people feel about this particular issue.
And very quickly, just because I'm running out of time here, do you foresee any special requirements you're going to have to put in place for the tracking of the data? Will mental disorders need a special type of analysis of the data apart from what we already have?
Well, we are collecting more data now, including for Indigenous populations in terms of MAID. So our next annual report should have more available data, which gives us a better disaggregated view of how MAID is being provisioned across the country.
Merci, Madame Voisin. Les prochaines.
Thank you very much. The next questions will come from senators. We'll start with Senator Meji. 3 minutes. Microphone, please, Senator Meji. Can everyone hear me? If the other microphones could be turned off beside Senator Meji, please. My question was answered by both witnesses here, in fact. What we are sensing is a degree of uncertainty and insecurity, even folks around this table. Now, as soon as we open things up, for example, to individuals with mental disorders or mental illness, it's going to be a free-for-all. That's the fear. Everyone with mental illness will have access to MAID. And yet there have been witnesses, even psychiatrists, who've said that in their 35-year-long career, she only identified 3 individuals under her care who would actually be eligible, given the very serious criteria, how chronic it was, the kind of medication the individual received. So not necessarily someone in an acute crisis. There are other witnesses that confirmed that assertion. What are your thoughts? You alluded to a lack of practitioners, clinicians, to perform these assessments. If one clinician has had to wait 35 years in her career to identify a couple of cases, well, I'll hand the floor to you.
Well, maybe I'll go first and turn to Dr. Downey. Just to say, I think we'd agree with those statements that just because you make this eligible for people with a mental illness, I think that their evaluation, the assessors right now are evaluating many Track 2 cases which involve people that have mental illness in combination with other conditions. So this is not, something that is new. Those are complex cases. And I think as Dr. Downey was saying, there's a requirement to consult with experts depending on the case and depending on what condition, is at issue. So just because you have a mental illness does not mean that you are suddenly eligible for MAID. It's a very high bar in terms of eligibility.
I would echo all of that. I would say we are going to have some requests. We will have very few people who will be eligible. We will have sufficient clinicians who are able to provide either as assessors or providers or as playing the consultancy role. I also want to emphasize that if nobody is available, because this came up maybe 2 weeks ago, if a clinician isn't available to act as an expert consultant, the person can't get made. It's not like an absence of the experts would mean that people are getting made without that protection, because it would be illegal to proceed with MAID without that consultation.
Merci.
So there's a protection built right in.
Thank you, Professor Downey. Thank you. Next.
Merci, Monsieur le Président.
Thank you,
Thank you, Mr. Chairperson.
Dr. Miji. Prochaine question sera posée par Madame.
Next question, Senator Wallen.
Thank you. Just for the record, the Senate did call for some safeguards on this question, and the government elaborated on that when it was sent over. So just the fact base there. So when we talk about, and I'd like to hear from all three because we've got different, when we talk about hiding behind the Constitution, it troubles me. Presumably, we want our laws and services to be constitutional and to be accessible. So I'm wondering if because we have not heard from the Department of Justice, maybe we'll start here and go that direction.
Can you hear me?
Yeah.
So I guess I'll start off by stating the obvious, that there are very diverging views on this topic. No court has ruled on whether or not the charter requires MAID for mental illness. If we look at the charter statements for former Bill C7 and for former Bill C39, they set out the charter considerations supporting the charter consistency of both prohibiting MAID for mental illness and permitting MAID for mental illness.
But I guess my question was really, but we want laws to be constitutional. We spend
Yes.
a lot of time
Yes.
on that in the Senate when we get bills from
Yes.
the other side.
Yes, of course.
Ms. Voisin?
Well, from the Health Canada perspective, I would say that we need to respect the jurisdiction of provinces and territories in terms of actually managing the healthcare system. And so in terms of how we were managing this file, we leave it to the provincial bodies, the regulatory bodies who have the oversight of medical professionals. And we are working very closely with provinces and territories to do what we can to support them in, developing and putting into regulation practice standards, et cetera.
I think that the respecting charter rights is the highest obligation of members of the House and members of the Senate. And so you should never pass legislation that you do not have confidence is consistent with the charter and consistent with the Constitution, so the division of powers as well as the charter.
You raised another point, Dr. Downey, on the lack of political preparedness or willingness of governments to embrace this is not a reason to deny Section 7 or 715 rights. Are you getting a sense that that may be an issue?
In less than 20 seconds.
Absolutely. I think that if you look at the arguments, that's all that's left. There's no solid evidence, there's no valid arguments that justify a further delay. Therefore, the only explanation is political.
Thank you, Mrs. Wallen. En remplacement du sénateur Kuchner,
Replacing Senator Kuster, Senator Ravalia, the floor is yours for 3 minutes.
And thank you to our witnesses. My question is for Madame.
Votre micro, allez-y. OK, c'est bon.
Your microphone, please.
In your dialogue with territorial and provincial partners from the readiness perspective, do you feel that the medical educational programs that have been established as a foundational element for clinicians practicing MAID have afforded enough knowledge from the mental health perspective to create a milieu that will ensure that there is safety and will annul any what we would consider bogus requests?
Yes, I think, as I said in my remarks, the curriculum includes 7 modules, and one is focused on mental illness. And it combines both online self-learning component, which discusses the many challenges that are inherent in making a decision related to, or an assessment related to mental illness. There's also case reviews, including mental disorders that are anticipated to be most commonly found in terms of those assessments, and there's even group facilitated discussions. So there's like a very comprehensive module on mental illness, and as Dr. Downey said, we've also done knowledge exchange workshops with experts, and we're getting more and more registrations for the curriculum. So I think that preparedness is growing, and with my PT colleagues, my provincial and territorial colleagues, we're discussing the next steps in terms of more detailed clinical guidelines, guidelines, oversight mechanisms, and how we can really share those best practices and make sure there's consistency across the country.
So in follow-up, Dr. Downey, do you feel that we've built in sufficient safety precautions in the assessment of those who are mentally ill who would be seeking this pathway?
Yes, I think so. I think it's in the criminal code, and then it's in the model practice standard, which is being reproduced in the practice standards across the country. And then you have the curriculum. I would also add that the people who are going to be doing the first sets of MAID for mental disorders as a sole underlying condition are not going to be new MAID providers. They're not. They're going to be very experienced MAID providers. We have psychiatrists across the country who've been engaged in MAID assessments and provision and also acting as consultants. Those are the ones who are going to be doing it. They are very experienced, very knowledgeable. They have decades of experience in psychiatry and years now in working in MAID. So we've got the experts. We've got training for the people coming up through. They will then be mentored by the experts. So yes, I think we are well established.
Thank you.
20 seconds.
Okay, so I'll just make a final point that I'm speaking as a clinician with 35 years plus experience in a rural and remote community dealing with very complex mental health issues. And in my practice, I've perhaps had 2 individuals who might have met this. And these are individuals who've had psychiatric care, electroconvulsive therapy, cranial magnetic stimulation, deep brain therapy, a variety of therapies, and they fail all of that. Thanks. And they live a lonely, dark existence. So let's not forget those individuals.
Thank you, Mr. Verlia. Monsieur Dalphond, à vous la parole pour 3 minutes.
Ms. Senator Dalphond, 3 minutes. Thank you very much, Mr. Chairperson. The Senator recommended a sunset clause when it comes to the exclusion of access to MAID on the sole basis of mental disorder for 18 months. The House of Commons extended that to 24 months, just by way of clarification. So the purpose of having 18 months was to be able to put in place a system that would protect Canadians. The report was clear on that matter. Now, the mandate of our committee is to, of course, uphold the Constitution. We amended the criminal code. We put in place very clear provisions. I understand, Professor Downey, that those provisions are very satisfactory. Our mandate is not to review or overhaul them, just to ensure that they're properly understood and implemented. Now, if I understood your presentation, Professor Downey, correctly, we're doing more than what's necessary. Well, because this is a provincial area of jurisdiction, not a federal one, but we need to ensure that the provinces do what they are supposed to do. But our constitutional obligation doesn't go that far, to be honest. Does it?
Yes, for you and maybe Mrs. Wills.
I'll jump in first and then hand it. No, it absolutely doesn't. And you've done more. The federal government has done more in respect of this aspect of MAID than it has for any other aspect of MAID in relation to the provincial territorial jurisdiction. The curriculum, that's medical education. The knowledge exchange workshop, medical training. The model practice standard. Colleges are it's done at a provincial territorial level. So the federal government has facilitated all of that, which has been extraordinary. And, you know, the fact that we don't have it for other things maybe is just we should take the point of, look, this can be done, and look how good it is when we work together and we build something like this, and then we get a harmonized system across the country. So, yes.
So, I guess I would say that all of government legislation, like Bill C-7, which expanded MAID for cases where reasonable death is not reasonably foreseeable, includes a charter statement that the Department of Justice and the minister must satisfy themselves that whatever is being proposed is constitutional.
Yes, but this is not really the issue of my question.
Okay.
My question is more, have we done that by amending the criminal code the way we did? And I think we did. And if we have done so, what we're doing now is more than what is constitutionally required. We are testing the water. We're making sure everything is going to happen as we think it should be happening. So we're not constitutionally bound to do that, but I believe we're going beyond to reassure Canadians.
So just to make sure I understand the question, that the safeguards in the criminal code are sufficient to protect. Yeah. So
10 seconds.
I think that ultimately that's up to Parliament to decide. I can't speak to any advice that's been provided to the government on.
Okay. Merci, Mrs. Wills. Madame Martin, floor is yours for 3 minutes.
Thank you, Mr. Chair. I just wanted to say I do share concerns with Mr. McGregor about the lack of consultation with the Indigenous communities. You said you have done some broad consultation, but nothing specific to, MAID and mental disorder. And we heard testimony previously from some of the members of the Indigenous community that there has been quite a lack of an absence of consultation. So that is quite concerning to me. But I'll ask Mr. Lemons, Professor Lemons, my question. Professor, I'm aware that you have recently been a member of an expert panel for the Jersey government that made recommendations about assisted dying legalization options. So I have two questions. Were any of the committee findings and legislative options informed by Canadian MAID law and practice? And was there any discussion about MAID mental illness?
Yeah, so thank you for the question. I should say that we were not mandated to discuss the rationale for legalization. So Jersey put forward two options for legalization. One was a terminal illness diagnosis, so it kind of style track one, but narrower than in the Canadian context. Second one was a very broad track, which compares to the Canadian track two. And I was not completely surprised, but I was actually happily surprised to see that my two colleagues, who actually are for legalization of assisted dying in some form, agreed, looking at the evidence, that the Canadian model was not the approach they should be taking. So we recommended against an open-ended access to MAID for unbearable suffering. Psychiatric MAID is explicitly excluded, as it is actually in most jurisdictions around the world, or in many jurisdictions around the world that have legalized some form of assisted dying, simply also because most jurisdictions limit access to MAID or euthanasia or assisted suicide to the end-of-life context to people who have a terminal illness diagnosis, which would not fulfill the criteria for, or mental illness would not fulfill the criteria of a clearly identifiable survival prognosis, terminal illness prognosis.
Well, you mentioned both Belgium and Dutch euthanasia regimes in your remarks, but do you have more concerns about MAID for mental illness in Canada than those other regimes?
In 10 seconds.
I think people have to realize a fundamental difference between Canadian system and Belgium and Netherlands is that we don't even have an obligation that physicians have to agree that all reasonable treatment options are fulfilled. So people who are saying, oh, there will be only a few cases, it was broader practiced already than a few cases in Belgium and the Netherlands. It is more broadly practiced. It will even be practiced much more broadly in the Canadian context.
Okay, thanks, Professor Lemon. Sorry, but we're so tight. So, nous n'aurons pas le temps de faire une deuxième ronde dans la.
We won't have time for a second round in the first hour, so we're going to suspend for the time being. Thank our witnesses. Welcome our witnesses for the second panel. Thank you to all the witnesses here in attendance in the first panel. Thank you.
Thank you.
Stephanie Green, Practitioner Advisor to BC Ministry of Health. We also have Ms. Julie Campbell, Nurse Practitioner for the Canadian Association of MAID Assessors and Providers. Finally, we have Nova Scotia Health, Dr. Gordon Gubitz from the Division of Neurology, Department of Medicine, by video conference also. So, friends, guests, where the timelines are tight, 5 minutes each, starting with Dr. Stephanie Green.
Very tight. Floor is yours.
Thank you for this opportunity. My name is Stephanie Green, and I'm a physician with 30 years of clinical experience. In June of 2016, I began working almost exclusively in assisted dying, and you may read of my credentials in my written brief. I have no personal or professional stake in the outcome of your deliberations, but I remain committed to providing the highest standard of medical care possible under any and all legislation. If the purpose of this committee is to, quote, verify the degree of preparedness attained for a safe and adequate application of MAID in MD Sum-C situations, end quote, your work should not be complicated. Clearly, there is a high degree of preparedness, and I point your attention to the numerous readiness activities plainly outlined in the written brief of CAMAP and those referenced by Drs. Mona Gupta and Douglas Grant, and tonight by Professor Downey. There is readiness at the federal level. There is stated preparedness by the medical and nursing regulatory bodies, as well as by professional associations. And clinical teams in British Columbia, Alberta, Saskatchewan, Ontario, and Nova Scotia have all confirmed their readiness, and I can speak more to this in our discussion if you wish. Regardless of what this committee ultimately recommends, I am most concerned it be based on fact and not on any fundamental misunderstandings. So I submit the following 3 points of information for clarity. Number one, consensus is not and has never been required in the development of medical practice. There is no consensus on many medical practices: hormone replacement therapy for women, safe injection sites, use of ketamine for treatment-resistant depression. And this lack of consensus is not taken as a reason or justification to prohibit these practices. There is no consensus among clinicians about MAID itself, and yet that did not and does not stop MAID from being permitted under the law. Medical practice does not start with training all clinicians before the practice is permitted. Rather, it starts with training some, who then train others over time. And only clinicians with the professional competence to provide the intervention are permitted to do so by the standards already published and already enforced by the colleges of physicians and surgeons or nurses in every province and territory. Any suggestion that consensus is required before moving forward with MD Sum-C is opposition to MAID, disguising itself as a benchmark. Number two, legislation is clear regarding MAID eligibility. We need to stop focusing our attention on a person's diagnosis, mental disorder or otherwise, and look to the eligibility criteria. The condition must be incurable, irreversible, unrelievable. Clinical understanding and implementation of MAID legislation continues to evolve and mature, and the recently published Model Practice Standard for MAID has contributed significantly to this understanding. As an experienced MAID practitioner, and as one who teaches others how to approach this practice, I would state as clearly as possible for your recognition that in situations of MD Sum-C, someone in crisis is not eligible for MAID. Someone who is newly diagnosed is not eligible for MAID. Someone who hasn't had treatment or who refuses all treatments with no rationale or who is seeking MAID due to socioeconomic vulnerabilities is not eligible for MAID. Number three, we have enough psychiatrists already involved to move forward. Legislation requires 2 independent clinicians find a patient eligible before they can proceed. For patients whose natural death is not reasonably foreseeable, a clinician with expertise in the condition causing the person's suffering must also be involved. Psychiatrists may therefore potentially play 2 different roles. They may be assessors or providers of MAID, although few will be required for this role, or they may be consulted as clinicians with experience in the condition causing the person's suffering. Psychiatrists are already being consulted as clinicians with expertise in many applications because they already possess the skills and training to be considered experts in their field. Canada has nearly 5,000 psychiatrists already adequately trained to continue to fulfill their role of expertise in MD Sum-C situations. Now, over 100 psychiatrists have already registered their interest in becoming involved in MD Sum-C, and this represents 2% of all psychiatrists in Canada. Last year, about 2% of all physicians in Canada provided 13,000 MAID procedures. I would suggest that 2% of our psychiatrists are sufficient to consult on what is rationally expected to be significantly fewer MD Sum-C cases. Preparedness for MAID Sum-C is clear. Please do not let misinformation distract or cloud your deliberations on this point. Thank you.
Thank you, Dr. Green. Now we will hear Mrs. Julie Campbell. The floor is yours for 5 minutes.
Thank you for inviting me here today. I'm Julie Campbell, a nurse practitioner and the Vice President of the Canadian Association of MAID Assessors and Providers, or CAMAP. CAMAP represents professionals who work in the delivery of MAID in Canada. CAMAP does not take a position on MAID for MD-SUMC. We are focused on and committed to supporting our members to provide the highest standard of medical care within the law. As part of this commitment, CAMAP has, over the past 2.5 years, developed the Canadian MAID Curriculum, or CMC, the first comprehensive, nationally accredited, bilingual, evidence-based educational program to support the practice of MAID in Canada. It aims to educate new MAID practitioners, advance the skills of existing MAID practitioners, and help standardize the approach to care by supporting those who deliver MAID care from coast to coast. On August 21st, the CMC was launched, and the enthusiastic response from clinicians exceeded expectations. Feedback from clinicians who have completed modules has indicated very positive responses when asked if they felt that their knowledge and confidence had increased. In addition to expertise in MAID assessment and provision, CAMAP members also carry a variety of clinical expertise in many areas, including psychiatry. Our members rely on colleagues who act as consultants in their area of expertise. When an assessment is completed for a patient without a reasonably foreseeable natural death, and for whom neither assessor has both expertise in MAID and expertise in the condition causing the patient's suffering, we rely on these consultants to provide their expertise in the condition to add to the assessor's expertise in MAID assessment. The difference between the role of assessor and consultant is important to understand. With our psychiatrist colleagues, they have, by virtue of their extensive training and expertise as psychiatrists, advanced knowledge on capacity decisions and mental disorders. We have utilized their skills as consultants for any patient who requires it. This is not specific to patients with MD-SUMC and may apply to both patients with and without a reasonably foreseeable natural death. For patients with MD-SUMC, we will utilize their skills once again. In Canada, there are approximately 5,000 psychiatrists who, by virtue of their education and skill, may act in the role of a consultant. There are included in those psychiatrists others who have sought and obtained expertise in MAID assessment. To date, more than 100 psychiatrists have begun or completed training with the CMC, demonstrating a significant level of interest of this subset of psychiatrists, who will then be both a source of expertise from their respective backgrounds and have expertise as assessors. Since 2016, we have safely assessed patients requesting MAID who also had comorbid mental disorders. Part of our thorough, thoughtful, and safe approach to eligibility assessment has always been to see the patient as a whole. To help our members, we have developed clinical guidance documents, such as Assessment for Capacity to Give Informed Consent for MAID, and MAID for people with complex chronic conditions. These documents have helped to guide our members to safely assess and provide for patients with complexities and have helped us develop experience that will be relevant to assessing patients with requests for MAID for MD-SUMC. As is standard in medical practice, we are evolving each day, sharing our best practices, gaining experience, and we now have almost 7 years of experience upon which to draw. We have organized and facilitated knowledge exchange workshops with representatives from across Canada. One knowledge exchange was focused on clinician readiness and the other on system readiness to ensure not only are the clinicians ready, but the other important members of our teams are also ready: nurses, social workers, and administrators, among others. We have hosted a 3-part fall symposium with specific learning around assessing individuals with mental disorders, and we hold monthly case sharing webinars. We have prepared diligently for the expiration of the sunset clause, and we are ready. CAMAP members are ready for the planned legislative change in March 2024 and will continue to provide compassionate, high-quality care to all patients considering MAID. Thank you.
Merci, Madame Campbell. Monsieur Dr.
Thank you, Ms. Campbell. Dr. Gordon Gubbitz, 5 minutes, please.
Nova Scotia. My name is Gordon Gubbitz. I'm very grateful to be able to speak to you today. I'm a professor of medicine and neurology at Dalhousie University, and I became a MAID assessor and provider for both Track 1 and Track 2 patients after legislation was passed. I'm also a board member for the Canadian Association of MAID Assessors and Providers and sit on their education committee. And I was the chair of the national group out of CAMAP that developed the MAID curriculum that you've heard about that was discussed earlier, and hopefully we'll have a chance to discuss in the question period. Excuse me. I'm also the clinical lead for MAID in Nova Scotia, and that involves working on a weekly basis with our administration in collaboration with the Department of Health to oversee MAID in our province. And I'm pleased to speak to you this evening on behalf of Nova Scotia as an example of other jurisdictions across the country to help you understand why Nova Scotia stands ready to move forward with caring for people who request MAID for MD-SUMC starting in March 2024. Each province and each territory will deal with this differently. In Nova Scotia, we have one central team, which is managed and overseen by a very strong administrative staff, skilled nurse navigators who triage and assess patients, and provide detailed assessments and referrals. We also have full-time nurse practitioners who work geographically to help provide MAID. And in the week of C7, in anticipation of the complexities of Track 2, we've recruited additional members to our team, including social workers, etc. Our team is involved in regular education with learners across the province. Importantly, our team meets on a regular basis every week on Friday morning to review challenging cases, as we call them. Many of these people have complicated medical problems, often Track 2 patients, many with underlying mental health issues. With respect to MD-SUMC, we recognized that we would need to start to do this work some time ago, and have been working for over 18 months to ensure that Nova Scotia was ready. We created a provincial working group to develop policies and processes that would serve the MD-SUMC population and were beneficial for all of the national work that was done to help guide us. Our plan was to be ready for the implementation by March of 2023. To do this, we hired additional staff with mental health expertise. Thus, one of each of our nurse navigators, nurse practitioners, and social workers has a clinical background in mental health. We're in the process of exploring psychology consultancy, and we are recruiting an MD-SUMC clinical lead in psychiatry. This person will hold a position similar to mine, but with a focus on mental health. And we will work, the two of us, collaboratively with our MAID team as our skill sets are similar and complementary. Our working group was chaired by 2 psychiatrists, one of whom also does complex MAID assessments where capacity is an issue. The working group included members of our core MAID team, hospital and community-based psychiatrist, a specialist in addictions medicine, a bioethicist, a psychiatry resident, and representation from our government. As the process moved forward, we included one of our social workers and a nurse navigator with mental health experience. The working group was tasked with completing a detailed scoping review of the various topics relevant to MAID and SUMC, and developed a detailed and practically useful background material and guidance documents that will support the clinicians in Nova Scotia in their day-to-day work. We also provided overall governmental recommendations. To this point, we have an ethical framework that has been based on a systematic review of emerging area of palliative psychiatry. We have detailed documentation and training materials for the required assessments, including a comprehensive process that focuses on determining capacity, voluntariness, irremediability, structural vulnerability, and understanding suicidality versus a reasoned wish to die. We also have clinical pathways, included modified intake processes that will be completed by the nurse navigator, specifically built for MD-SUMC. We've followed along with a specific recommendation. One of the 2 MAID assessors in Nova Scotia must be either a psychiatrist or an addiction specialist, depending on the case. We are engaged in prospective review, similar to our weekly complex case discussions, and thus our Track 2 discussions every Friday morning will increasingly begin to involve people with mental health as a sole underlying condition. We will also be undergoing retrospective case audits for each person who completes the process of MAID using a standardized process. We've developed post-intervention supports for clinicians and families and friends. In conjunction with CAMAP, are developing training programs, including the modules have been described previously, and looking at compensation models. We shared all of our documents with the other jurisdictions across the country, as Ms. Campbell has outlined in the presentation that she gave, and have engaged in some really interesting provincial and territorial discussions. Over the coming months.
Thank you, Dr. Gubbitz. You can elaborate later on with through the questions that will be asked to you. So, les prochaines parties, ce sera des...
Now we're turning to a question and answer period, 5 minutes with each political party. Mr. Cooper first.
Thank you very much, Mr. Co-Chair. Dr. Green, I want to clarify that you are appearing in your capacity as an individual and not on behalf of the BC Ministry of Health, correct?
We can't hear you. You're muted.
Thank you. Yes, I am absolutely here tonight as an individual practitioner and not on behalf of any organization.
You had indicated that with respect to the CAMAP curriculum, that it was first rolled out on August 31st. It's my understanding that there are 8 different modules. How many professionals have been enrolled in Module 7, MAID and Mental Disorders?
I'm sorry, who's the question for?
It's for Ms. Campbell.
Thank you.
I have that data this evening, but I could provide it.
Has only very recently been rolled out or may not have been rolled out. Is that correct?
It has been rolled. Module 7 for mental disorders has been rolled out and has occurred in numerous locations. Maybe perhaps Dr. Gubitz has more information on that as well.
Yeah, once again, I'm sorry, I don't have the specific numbers, but the modules, as they are in the process of being rolled out, require interested practitioners to apply, to register, to go through the online pre-learning and then the facilitated modules. So you are correct. There will be increasing numbers over the coming months who will be involved in the training, but several groups have gone through already.
Thank you for that. What criterion is set out in the CAMAP curriculum with respect to assessing irremediability in the case of mental illness with certainty?
Again, I'm not sure who it's for, but I'd be happy to answer.
Ms. Green, I'm asking, this is a question
to
for CAMAP. I was asking about CAMAP curriculum. I would expect CAMAP would answer.
Sorry, can you repeat the question?
Is being eaten by... Am I losing time because they keep... Well, this is ridiculous. What criterion is set out in the CAMAP curriculum with respect to assessing irremediability in the case of mental illness?
So the CAMAP curriculum is quite comprehensive, and each patient is assessed individually using the expertise of people like psychiatrists for those patients. So we would be consulting with them. I'm not a psychiatrist. So if I had that patient, I certainly would be consulting with a psychiatrist around that patient, not just on one condition, but the patient as a whole.
On a case-by-case basis. Is that the guidance?
That's right. Each individual is an individual and has a myriad of conditions, just like we've seen for the past 7 years. Patients with cancer can have mental disorders.
There's no listing of criterion, and here's what you look for to determine irremediability. With certainty, because that was an issue, predicting it with certainty.
I think Mr. Gubitz raised his hands.
Yeah, perhaps I could help, sir. With respect to the curriculum is a case-based curriculum, and it begins with a series of cases which become increasingly more complex as they go through the discussions. some of the early cases, the person who is experiencing the mental health issue clearly would not qualify for MAID because they did not meet criteria, all the way through to more advanced cases where the clinical
sure,
course
but
of
I'm
the patient has
asking,
been
what is
demonstrated
the
to become
criteria?
irremediable.
What is the criteria? And further to that, what science is it based on?
So at the present time, the criteria are based on the ability of the clinician to assess the patient and provide a diagnosis and to provide a prognosis based on their past history, how they've been treated. As Dr. Green mentioned in her remarks, a person who has just been diagnosed with a healthcare problem would not be eligible. A person who had refused to consider various different treatment options would not be eligible. The sorts of patients who would be eligible would be those who have been treated for many years.
What I'm hearing you say is that there are no criterion, that we're back to where we were a year ago with the expert panel report, that this is going to be decided simply on a case-by-case basis. I see the model practice standard.
Thank you, Mr.
There's
Cooper.
no guidance there either.
Thank
so
you.
what we have is no guidance.
Thank you, Mr. Cooper. Madame Koutrakis, à vous la parole pour 5 minutes.
The floor is yours, 5 minutes.
Chair. And I guess this is a good segue after my colleague Michael Cooper's questions. And I'm just wondering, and any one of our witnesses can answer this, what steps were taken to ascertain the training needs of MAID practitioners, in particular with respect to MAID MD SUMC? Any one of them, whoever feels
Sure.
best to answer.
I can begin. When the training curriculum was developed, it was based on other curricula that the Canadian Association of Medical Assessors and Providers had been doing on an ongoing basis anyway. And each of those experiences resulted in evaluations about the content, about future needs, about things that we would like to do to become better MAID assessors and providers going forward. A lot of that focused then on providing a detailed basic assessment all the way to more complex things, including complicated track 2 patients and mental health sole underlying condition, recognizing that nobody has practiced mental health as sole underlying condition yet. So there will be some learning to go going forward.
I would add to that the curriculum project also did a needs assessment as they were beginning the process of developing content, and that was a large survey across the country, multiple clinicians, both those with and without experience, seeing what they were looking for, what they were seeking in an educational program, and we took that along with the evaluations that we'd had from the past 7 years of CAMAP training experiences to put together with the combined subject matter expertise of the committee of people developing the content. So there's quite a number of input on the content development.
Does Ms. Campbell want to chime in, or?
Yeah, and that module was also piloted. And so we took the feedback that comes from each module to determine whether it met that needs assessment as well. So the project came from that broad space of what, based on other curriculum, and then what do we need? And then moved forward into development with a whole series of experts and stakeholders and reviews. And then when it was piloted to a group of people, and that information reviewed as well.
Ms. Campbell, when you say experts and stakeholders, would you be able to clarify for us whether that included, Indigenous communities, persons with disabilities, persons with mental disorders, or any other potential vulnerable groups?
It did. And I can, I don't have a list in front of me, but we certainly can submit a list if you're interested.
That would be great. And also, how long did it take to ascertain the training needs? I mean, was this over 2 months? Was it over a year? How long did it take to ascertain what the training needs would be?
Do you want to take that, Gord?
Dr. Gubitz?
Sure. So as mentioned, the training needs were an ongoing assessment from the very beginning of CAMAP's origins in terms of how it was training individuals. The survey that we did across the country took the better part of 3 or 4 months. It was completed in English and in French in various jurisdictions and then had to be compiled. And from that came the 7 modules with the 8th additional module looking at the resilience of practitioners, which is woven through the other modules.
Dr. Green, are you aware of any significant differences between the model practice standard for MAID and standards that have already been established or are being developed across Canada?
I would say that before the model practice standards were produced, there was a lot of discussion and guidance regionally to help understand how the legislation itself might be applied in a clinical situation. As Dr. Downey mentioned earlier tonight, there's legislation that's in law, and then there's clinical practice. And so we have to find some understanding of whether certain situation criteria have been met under law, and that's a clinical decision. I would say that the model practice standard for MAID has been a significant help for those of us who are doing this work in fleshing out some of the nuances about some of the wording that's in the legislation. One of the examples might be irremediable that Mr. Cooper mentioned earlier, or incurable, and what exactly that means and what goes into satisfying that criteria. That kind of nuanced fleshing out of the meaning has been extremely helpful to clinicians, and that's why I expect that most regulatory bodies have decided to adopt those standards.
Merci, Madame Green. Merci, Madame Kotarkis. C'est déjà.
Thank you very much. The time is up. Mr. Thériault, the floor is yours for 5 minutes. I'll just turn my mic on. 5 minutes goes very quickly, so I'll try to be as concise as possible. Well, listen, please train me. Please inform me. Please tell me, Dr. Green, you said earlier that certain individuals would not be eligible. What would be the typical patient?
Well, that's a good question. We haven't seen these patients yet, so I could only hypothesize for you. But I think that the typical patient who will meet these very rigorous criteria would have to be someone who's had a very long documented history of interacting with the healthcare system, where they've had numerous treatment trials, documented which ones have worked, which ones haven't worked, and how long they've had each treatment trial. They've likely had a number of hospitalizations. They've likely seen a number of specialists over the years. And it would require all of that to be not just having lived that experience, but having documented in the system before I, as a clinician, could come up with what's called a medical opinion about whether they meet the criteria of incurability or irremediability. So very unfortunately, there will be patients who had that lived experience who either didn't have that documented or who weren't seen adequately through the years by our medical system for a number of different reasons. And without that robust history being documented, they likely will not be able to be found eligible for this care.
Bon, je comprends.
Well, thank you. I understand, although it's a tad vague and opaque for me. Perhaps it's not possible to do better than that. But so as psychiatrists, the onus is on you quite frequently to determine whether a patient is a danger to themselves. Is that correct?
Quelqu'un me dit oui ou non.
Yay or nay?
Personne me dit.
Vous êtes
oui
en
non.
sourdine, Madame.
You're on mute, Dr. Green. I'm losing a bit of my time, says Mr. Thériault.
Sorry, I'm not a psychiatrist, but for every clinician, it is our duty to assess each patient for suicidality, and we have been doing that not just in the context of MAID, but in our clinical practice for most of our careers. That is correct.
Moi, ce qui me préoccupe, c'est...
What I'm concerned about is resistance to change. So how does one establish a difference between a patient who is in a danger to themselves and just a simple willingness to want MAID?
I think most of us have experience over the years of assessing this difference. It can be complicated, but for a very simple example, I might say that somebody who has a plan to harm themselves, has a timeline in which they would do it, has a means of doing so, and is expressing that, is having a kind of an intuitive reaction to a negative factor in their life, might be seen as someone who is acutely suicidal. Somebody else who's requesting MAID might come in and tell you they've been talking about this with their family for months or years, explain to you what their disease trajectory has been, what their values are, why they believe that there's no longer any meaning in their life, or why they might want to choose to end their life, and would be willing to work with the team and the clinicians to see if that's a possibility for them or if there's other resources available. There's a distinct difference between the two.
Dans la formation que vous êtes en train...
Now, in the training that you're developing on mental disorders, have you operationalized recommendation 16 of the experts' report, which includes prospective oversight, as it were?
In the curriculum program, we recommend following the practice standards of the local jurisdiction in which you're practicing. So if the local jurisdiction, say in Nova Scotia, as Dr. Gubitz talks about, requires that a psychiatrist must be one of the assessors or seen as part of the team, then we would encourage our learners to do so in Nova Scotia. That may or may not be the case elsewhere. It's the same with whether there's prospective oversight or not.
Par exemple,
Sorry, but I'm concerned about preparing things out on the ground. Quebec decided not to move forward with this, so what will be the ramifications for Quebec patients?
Well, that will be up to the CMQ, which up until now, my understanding has said that clinicians, if they follow one of the laws, provincial or federal, as long as they follow it in good faith, they will not be disciplined. I don't believe the CMQ has commented specifically about this particular situation, but certainly publicly they've stated they're against an exclusion, so we'll have to see what they say after March of 2024. In the meantime, clinicians are preparing on the possibility.
Thank you, Mrs. Green. Merci, Monsieur Thériault. Monsieur McAllister, à vous la parole pour...
Mr. McAllister, the floor is yours, 5 minutes.
Thank you, Chair. It's just Mr. McGregor. It's okay. If I ever write a book, I'll go by the pseudonym Gregor McAllister.
I'll start the time. Sorry, I'll start better time.
Okay. Thank you. Thank you to all of our witnesses for joining us and helping our committee go through this topic. Dr. Green, I'd like to start with you. I appreciate your opening comments that you've provided to the committee. I guess I'm curious in the development of the curriculum, and we now have the latest module entitled MAID and Mental Disorders. Are you able to inform the committee, like, when that module was being developed, like in the early days when you became aware that Bill C7 had passed Parliament, and this is something that you had to start preparing for? Initially, in the development of that module, are you able to inform the committee, like, what were some of the initial feedback or concerns that you were getting from people whose expertise is in this area? Like what were some of the dominant themes that they were bringing back that really sort of helped inform the development of this particular module?
Well, the curriculum put together a group of experts to develop this content, as with all the other topics in the curriculum. And we asked them for guidance on how we should move forward and allowed them a certain leeway. They certainly looked to other jurisdictions around the world where this is already legalized to see what they could learn from those jurisdictions about what's working and what's not working. They certainly also collected a number of experts from across the country, mostly coming with specialty knowledge, expertise in the conditions that are primarily seen in other jurisdictions where this is legal. So perhaps, for example, those with a specialty in mood disorders or substance abuse disorders. And so they gathered a kind of diverse group of subject matter experts from within Canada who have that generalized expertise based on what we were seeing in other jurisdictions that might be relevant to our experience. And then together, I was not on that committee, but they would then work together to develop the content itself, which then was reviewed by over 100 different reviewers in this country from a multitude of stakeholders from across the country. There were, I believe, 18 different national stakeholders that reviewed our content before it went to the board for final approval.
Thank you. Ms. Campbell and Dr. Gubitz, do you have anything to add from your own personal experiences in this journey? Anything you wanted to ask you, Dr. Gubitz? Please go ahead.
Sure. Thank you for the question. I think that there were some resounding themes as the module was being developed. They decided, as I mentioned before, to go very case-based because that's where the meat of the matter is. and facilitated discussions. So the people who are teaching are actually subject experts in the area who can lead people through a very nuanced conversation that deals with capacity, that deals with voluntariness, that deals with irremediableness, the structural vulnerabilities that Dr. Downey had mentioned in the last session. And then the concept of, as Dr. Green was talking about, is the patient suicidal or do they actually have a reasoned wish to die, which is not the same thing. And so all of those areas where clinicians struggle is basically the meat and potatoes, if you will, of the various different cases in the training module, going from fairly simple to more and more complex, and recognizing that there probably are more complex cases still. And the modules will be reviewed and evaluated and upgraded over time to reflect current practice and may include other examples going forward.
Thank you for that. Ms. Campbell, did you have anything to add or no?
Yeah, I think what we can add to that is the curriculum is a really important piece of this, but also those other forums where that richness that Dr. Gubitz was explaining in the case-based review of patients also happens in other areas in which we've gathered to become more ready. So in the workshops, in the online forum, in the knowledge exchange. So that all comes together where we look at patients as individuals, because there isn't a list. You know, when the law was originally written, they didn't write a list of conditions that were eligible. They listed criteria because people don't fit into boxes very well. They are very complex. And so this review of individuals and cases and gathering information from everyone in the room, facilitated by an expert, really brings out a lot of that discussion.
10 seconds.
It's okay. Thank you.
Mr. McGregor, sorry again. Thanks. Next questions will be asked by senators, en commençant par Madame la sénatrice Dr. Mégy.
Senator Dr. Mégy, 3 minutes. Thank you very much, Mr. Chair. Now, I thought I heard earlier a question about the duration of the needs assessment. Now, to gain experience in professional development and training, I'd like to ask the witnesses how the duration of the training per se has a bearing on the modules that you're developing. Is professional ongoing different? Professional training different? Could you clarify, please?
Madame Campbell or Dr.
Ms. Campbell or Dr. Green?
Madame Campbell?
So you're asking if the module training and the hours put into that is different than ongoing professional development? I would say they're complementary. So the modules provide certainly a basis of learning that supports that standardization, but we continue to learn. You know, what we knew in 2016 isn't what we know today, and that ongoing professional development only adds to the basis of the curriculum.
Dr. Green?
Dr. Green.
Yes, I'm not sure I understand the basis of your question. I would think that the curriculum project is, in fact, ongoing professional development. If you're talking about the medical schools and nursing schools, you know, we're hoping to be in that space.
Well, it's because I just heard a question earlier for you. Sorry to interrupt you, but I'd heard questions around the table such as, does the duration of the evaluation of assessments have any impact on the modules themselves? And I would venture to say that no, the needs assessments are time limited, but is it different when it comes to ongoing professional development and then specific to MAID modules? Is there a distinction to be made?
In 30 seconds.
I'm sorry, I still don't understand the question. The needs assessment that I was referring to before was in order to develop the content of the project. That is an ongoing months-long process that was done in combination with gathering of evaluations from other training sessions that had happened in the previous 7 years. So an abundance of information from previous training, ongoing training, the needs assessment itself, which was a separate assessment specifically for this particular curriculum development, all put together to help inform the subject matter experts as they developed and implemented the content for this curriculum.
Thank you, Madam Green.
It's all a crescendo of coming together.
Thank you, Dr. Green. Dr. Revelia.
Thank you, Chair. And my question is for Professor Gubitz. Professor, could you clarify for me the process and potential timelines that an individual with a treatment-resistant or incurable mental illness would have to follow prior to being considered?
I've lost audio. There's no sound.
Okay,
unable to hear.
I'll stop the time.
Me too.
Okay, can I try again?
Est-ce que le son est
Can we hear?
now?
Hello?
There you are.
Can you hear me? Hello? Hi? Should I try this speaker maybe? It is open, yeah.
The
Testing.
floor audio is muted.
The floor audio is muted.
Wow. We've got unmuted in there. We are unmuted.
Just be patient, a few moments.
Still cannot hear the floor.
Yeah, it's. We're gonna try to fix that.
Testing. Hello?
Yes.
Wait. Go ahead.
Okay. Thank you very much. So this is a question for Professor Gubitz. Professor, could you clarify for me the process and potential timelines that an individual with a treatment-resistant or incurable mental illness would have to follow prior to being considered for MD-SUMC? I'm asking this for clarity, given the rather angry, condescending, demeaning, and sometimes ludicrous non-scientific inaccuracies regarding access to MAID for MD-SUMC that's being bandied around. Thank you.
Thank you very much for the question. I think the essence of the answer is that the patient who is asking for medically assisted death would have to be able to provide a very, very detailed history, or a detailed history must be able to be provided about them. And that often would come from multiple sources. For patients with psychiatric and mental health disorders, often this is through collateral investigations through psychologists, through detailed review of patient records, through collaboration with previous family physicians, counselors, family members, etc., in order for a psychiatrist to come up with an overall diagnostic impression, and as well to be able to assess whether or not all of the avenues have been explored reasonably to ensure that this patient has been or has attempted to use all of the appropriate treatments for them. So as Dr. Green mentioned, it's not a snap decision. These are track 2 patients. It's going to take months to evaluate many of these people to try and figure out if they're eligible.
Do I have some time? Dr. Green, if you could follow up then and tell me, based on your clinical experience, the numbers that would qualify in this situation, would you be able to perhaps just hazard a guess? Are we talking teens, hundreds?
I think we're talking small numbers, less than hundreds for sure. We're talking teens. I think, in the number of patients I've seen over the 7 years, there have been hundreds of patients I've seen. Very few have come forward due to mental illness up until this point. I cannot imagine there'll be very many out there who will be able to meet all the rigorous standards. The eligibility criteria are rigorous. The safeguards are robust. It will be quite difficult for those with mental health disorders. So I would say probably for every 100 that apply, I would imagine 1 to 2 might be eligible.
Thank you for your clarity on those safeguards. Much appreciated.
You still have 20 seconds?
I'm done. Thank you.
Thank you, Dr. Revelia. Madame Willen.
Very much. I want to follow up on the same theme as Senator Revelia there, which is the concern that's often raised is about whether there'll be too much access to MAID for those with mental illness. And it seems to me that given what you've said, Dr. Green, and what you've said, Dr. Gubitz, that the issue is really on the other side. The concern is about access to it. You've both highlighted the fact that it's going to be very difficult, that you're going to have documentation that people with mental illness might not be able to provide, that you're going to have to see the earlier documents from people who have treated them in another way, whether or not they actually have the capacity to put that all together. What is, and we'll go to Dr. Green first, what is your most serious concern coming at it from that perspective?
Well, I have the privilege of sitting with people when they come to me in a desperate situation asking for me to help them end their life, which is a very intimate time. When someone comes to do that, they are often desperate, and there are times when I have to tell people they're ineligible. I think the greatest risk here is that people, I'm not a legal scholar, but people cannot be told that they're not eligible for legalized medical care in this country based on a diagnosis. That seems blatantly discriminatory. So I think that the biggest risk here is people feeling they've been excluded from accessing care that others are able to access. And the risk then will become what they will do in that situation.
And Dr. Gubitz, I mean, that's what we've been hearing in testimony, that, if you're going to make the constitutional argument that they have the same right as others to seek MAID, we've put a lot of barriers in this particular category.
I would agree. I think for us in the group that we're working with in Nova Scotia, the question becomes, what happens to people who apply for a medically assisted death but who are not eligible? Who cares for them then? Because our MAID Access team in Nova Scotia is not a treatment team for people with mental health disorders. Sometimes these people lack some of those basic circumstances. They don't have a family physician or a nurse practitioner to care for them, even for their primary needs. So for us, it's then a discussion with our government to say, how do we care for these people if they're not eligible?
We heard that before, that we need two tracks in the other sense, that there has to be money and system readiness on this side, but there also has to be money and services and system readiness for those that cannot access MAID but still struggle with mental illness. Dr. Gubitz, go ahead.
Sorry, Mrs.
Yes,
Williams. Sorry, Dr. Gubitz. It's still the time we have. Sorry. Madame Martin, the floor is yours for 3 minutes.
Yes, thank you. I want to go back to Ms. Campbell, and I know I didn't hear the answer specifically to my colleague about the criterion that is set out in the CAMAP curriculum with respect to assessing irremediability in the case of mental illness with certainty. So I know you talked about the cases that are discussed, and it's a case-by-case basis, but certainly there must be sort of criterion that is discussed, a list of things that you're instructing the MAID assessors.
I think, there's this wish for a simple checklist that doesn't exist because people are complicated, right? So if we take an individual and we follow what Dr. Gubitz has just outlined for you, we're talking to their psychiatrist, we're talking to their psychologist, we're reviewing their conditions, we're asking about what treatments have they tried, what treatments worked, what treatments didn't work, what was the result of those. And it's the answer to those questions that's starting to build a picture around irremediability. It's not just as simple as, do they have this condition? Is it irremediable? And it really is an in-depth, thorough review of that patient, all of the people that have been involved in their history, and what does that look like?
Okay, thank you. Well, it's not a wish list. It's not a wish, but rather we're trying to ascertain the the quality of training, and so that we're talking about people's lives, whether it's tens or hundreds, we're talking about individual lives. So maybe for assurance, will you be able to provide the committee access to this module? Because I know as a former educator, seeing it in print, and that would definitely give us some assurance. So is that something you can provide to the committee? Ms. Green? Ms. Campbell? Can CAMAP provide the module that is being used to assure us of, just for us, I mean, we are not experts, but at the same time, seeing it in writing will give that sort of assurance. So I believe that the training is being undertaken, and I know everyone is learning the practice, but it would be important for us to see that module. Is that something you could provide?
It's a question I could certainly ask of the board, but it's not a decision I'd like to make independently at the moment, unless Dr. Gubitz or Dr. Green has more information.
Dr. Gubitz, just quickly, you mentioned in your remarks that there's an addiction specialist that was recently hired. Is that correct?
We had an addiction specialist who was part of our provincial advisory group developing the documentation.
Does that mean that you're also anticipating that potentially people with addictions would be eligible or considered?
It's entirely possible. Yeah, as long as they met all of the criteria, it's possible.
Thank you, Dr. Gubitz. Merci, Madame Martin. Les prochaines questions.
Next questions will come from members of Parliament. Ms. Cramp-Newman, 3 minutes.
Madame Shelby Cramp-Newman, floor is yours for 3 minutes.
Sorry. Let me see.
3 minutes.
Yeah, my ears cut. Sorry. Jeez. There we go. Okay, so I have some concerns. Has there been actual conversations and real life conversations with individuals with lived experiences of mental illness that have been, and have they been adequately consulted with respect to the potential implementation of enticed suicide to escape a very painful death? Stephanie, if you'd like to, or Ms. Green, if you'd like to answer that.
Dr. Green, yes.
Thank you.
I can tell you that we have been fortunate enough to involve people with lived experience on several of the content committees for the development of the curriculum, MAID curriculum project, and in particular for Module 7 on MAID and mental illness, which is not only about MD Some-C, but also when mental illness is a comorbidity. There was a person with lived experience on the committee developing the content. So there has certainly been an effort to do that from the CAMAP curriculum point of view. If that answers your question.
I can move on from there. To my knowledge, and what we've gathered earlier, is that there's no real solid data about socioeconomic factors driving requests for MAID for individuals with mental illness. So if we're providing marginalized, lonely, homeless, and potentially suicidal people a premature death based on unscientific medical assessments, I'm concerned where we're at as a country, and is Canada ready for this?
So there's no evidence that people with those characteristics are actually requesting and receiving MAID in a higher proportion in Canada. We actually have evidence to the contrary. The increased data that's being collected right now by Health Canada since January of 2023 will be reported in 2024, and will give us a more fulsome picture of people who are requesting and receiving MAID. So I think that would be helpful. But as with other jurisdictions around the world, we absolutely do not see those drivers for MAID, and we don't expect them to be in Canada. And we know very clearly from the very clear eligibility criteria that socioeconomic vulnerabilities on their own do not allow someone to become eligible for MAID. Obviously, people are, as Ms. Campbell mentioned, quite complicated, and it's hard sometimes to discern out which factors are involved. It's not to say that people with those factors do not come forward and ask for MAID, but there's a difference in a screaming headline that says someone with vulnerability is trying to access MAID. There's a difference between being assessed for MAID and being found eligible for MAID, and I think it's important that this committee keeps that in mind.
Thank you, Dr. Green. Merci, Madame Newman. Monsieur John Eldag, for 3 minutes. Oh, Mr. Scarpoleggia, sorry, for 3 minutes.
Thank you very much. A couple of quick questions. I forget who said it, but I think maybe it was Dr. Green said that a person to be eligible for MAID in cases of mental illness would not have been basically allowed to refuse treatment in the past. Is that correct? Did somebody say that? Did I understand correctly?
What I said was if somebody has been offered treatments and refuses them and gives no particular rationale for why, they can't just come forward and say, well, I refuse those treatments and therefore I'm still eligible. That is certainly not the case, and they would not be found eligible.
Yeah, they'd have to have a reason. So, because, I'm sure there are many, a person, for example, may have tried many treatments, but then balked at one particular treatment. For whatever reason, they just didn't want to have electroshock therapy, and maybe that might not be considered a sufficient reason, but they wouldn't be disqualified because they refused one of many treatments. The evaluation is a little more subtle than that, I would imagine.
The evaluation is much more subtle than that, and we would look to see maybe they've tried a similar medication and found the side effects unacceptable to them. But so every case is different, case by case.
Now, what I heard was that when it comes to irremediability, it's very complex. You have to look at the whole situation, and there's no kind of test for irremediability. But I just would like your opinion on an abstract from an article in the Cambridge University Press called "Irremediability in Psychiatric Euthanasia: Examining the Objective Standard." And I'll just read you the abstract, and maybe you just could comment on it. Irremediability is a key requirement for euthanasia and assisted suicide for psychiatric disorders. Countries like the Netherlands and Belgium ask clinicians to assess irremediability in light of the patient's diagnosis and prognosis and according to current medical understanding. Clarifying the relevance of a default objective standard for irremediability when applied to psychiatric EAS is crucial for solid policy making, yet so far a thorough examination of this standard is lacking. Now, this was published only a year ago. I would just elicit a comment one way or the other on this particular article. Dr. Green?
Vous êtes en sourdine, Dr. Green.
You're muted, Dr. Green.
Sorry. I'm very sorry. I think at this point, this question has come up repeatedly. I think what I would do is I would encourage the members of this committee to review the model of practice standards for MAID, where these notions of what irremediable means is fleshed out. I can't find it right in front of me right now, but there is a paragraph that explains what goes into something being incurable or something being irremediable or something being irreversible. And by no means are they the end-all and be-all, but they give a sense of what all is involved in this. I do have one paragraph in front of me.
Thank you, Dr. Green. Sorry, 3 minutes is very short. Monsieur Thériault, à vous la parole pour 2 minutes cette fois-ci.
Mr. Thériault, 2 minutes. Thank you. So if I could just sum up your testimony, the 3 testimonies, there are very few people who would be eligible given the parameters that you've elaborated upon. For example, the individual has to have tried everything, not refused any treatments that we know without a shadow of a doubt would have helped to improve the individual's condition. So if there are so few people who would be eligible for MAID, given all the guidelines and yardsticks that you have set up, could one claim that MAID and opening up to mental disorders could have a preventative benefit to it? Who'd like to take a stab at that? Dr. Gubitz, I haven't asked a question of you yet.
Sure. So I think we know for MAID in general that the involvement of a MAID assessment will often improve the health care of the person. For example, if they've not accessed palliative care services and they do, and they find some benefit so that they don't have to have a medically assisted death and can die comfortably under the care of palliative care. That's an example, generally speaking. I think if we are being truthful about how we assess people with mental health disorders, we really sometimes need to really push the standard a bit and go into the depths and say, what have you tried? What have you not tried? Oh, I found this is something you might be interested in thinking about, and it's something that we could trial to see if it makes sense for you. And that's the reason that we have to have people who have an expertise in the subject area. As Dr. Downey mentioned the last time, it doesn't necessarily need to be a psychiatrist, because many primary care physicians who've been looking after certain populations of patients are experts in their treatment. So it's really about knowing the condition, knowing the patient, and getting a sense of, have I really done my due diligence in caring for this person?
Thank you, Dr. Gobitz. And for the interprets, please, as much as we can, we should speak very slowly. I'm used to being told that. Mr. McGregor, the floor is yours for 2 minutes.
Thank you very much, Mr. Chair. Dr. Green, I guess I will finish this round with you. You know, if it had not been for Bill C-39, which Parliament passed really quickly, we would, of course, be living in a country right now where mental disorders as a sole underlying medical condition would be eligible for MAID. Looking at it from British Columbia's perspective, how did that additional year factor into the degree of preparation in our province? And approximately, like, according to you and how involved you are in this, like, when was the determination made that our province was ready? I just trying to sort of walk backwards in the timeline here.
Yeah, British Columbia has always been having some foresight and seeing things come down the pipe. So, for example, British Columbia developed a provincial working group that's been preparing for MAID-SOMC since September 2022. We certainly took the extra time. It's been over a year now. That subcommittee is a subcommittee of a different committee of the Ministry of Health that took the expert panel recommendations and took the model practice standards into account, and has now proposed new provincial safeguards with the creation of a case review committee for all MD-SOMC cases, for example. 3 of the regional health authorities are already ready to establish those case review committees. One of them is already running something very similar to that. And certainly all of them will be ready by March 2024. You know, both our regulatory authorities, the medical and nursing colleges, are making changes to the medical practice standards for the province based on the model practice standards and the working group's recommendations. So I think with all that work having been done in the past year, the province feels ready to move forward. When did they say they were ready? I would say they're saying it now as they realize things are falling into place on time. Did we take advantage of the extra year? Absolutely, we did.
Thank you, Mr. McGregor. Merci, Madame Green.
I have a point. I don't know what to call it, whether it's a point of order. I'm just not sure we should be requesting access to the professional training for a professional body. I don't know whether that's appropriate. I know they were going to go back to the board and ask about it, but I think that's kind of a questionable request, that's all.
Madam Chair, let me just say that I guess for CAMAP it's one big secret, but then this is, again, an organization that had training programs in which they were discussing, among other things, sedating patients who were resisting the administration of MAID. That's what we're dealing with CAMAP.
It was just a point. I just would want to put that on the record. So that's it. I don't think it requires
Okay,
any
thank you.
debate.
I'd like to thank all the witnesses, and we will suspend momentarily to welcome the next witnesses for the third hour. So, merci beaucoup à témoins. Nous suspendons temporairement.
Colleagues, we will resume at this time. And with that, welcome our main witness, but there are two that you will, we have a second person that is there in case there is additional backup needed. But we welcome Dr. Jatinder Sareen, physician with the Department of Psychiatry by video conference, accompanied by Dr. Pierre Gagnon, director of the Department of Psychiatry and Neuroscience at the University of Laval. So welcome to you both. So Dr. Sareen, you will have 5 minutes for your opening remarks, and then we'll go right into the first round of questions. So we have one witness doing the testimony to start. So Dr. Sareen, the floor is yours for 5 minutes.
Thank you so much, Chair. Can people hear me okay? Thank you for the opportunity to speak to this special Joint Committee on Medical Assistance in Dying. I'd like to acknowledge that the University of Manitoba campuses are located on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories, and we acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with our Indigenous communities in a spirit of reconciliation and collaboration. With regard to this testimony, I have no conscientious objection to MAID. I'm an adult psychiatrist with clinical and research experience in suicide prevention for over 20 years, with over 400 peer-reviewed publications, 150 in suicide prevention. In 2019, I testified on behalf of the Attorney General of Canada in the Truchon case. I co-chaired the federal 2016 expert panel on suicide prevention in the military with Dr. Rakesh Jetley. Today, I'm representing the Department of Psychiatry at the University of Manitoba and Shared Health in Manitoba. I'm here with Dr. Pierre Gagnon, Department Chair of Psychiatry at University of Laval. But we are also representing 6 other department chairs of psychiatry departments in multiple provinces in the country. Jack Haggerty from Northern Ontario School of Medicine, Karen Neufeld from McMaster, Gustavo Turecki from McGill, Sarah Noble from Memorial University, Simon Hatcher from University of Ottawa, and Leslie Flynn from Queen's University. Collectively, we have decades of experience in clinical practice, suicide research, and responsibility for education and training of psychiatrists and medical learners. We strongly recommend an extended pause on expanding MAID to include mental disorders as a sole underlying medical condition in Canada because we're simply not ready. In our experience, people recover from long periods, long mean decades, of suffering with depression, anxiety, schizophrenia, and addictions with appropriate evidence-based treatments. We strongly believe that making MAID available for mental disorders will facilitate unnecessary deaths in Canada and negatively impact suicide prevention efforts. The clinical role is to instill hope, not to lead patients towards death. We have carefully reviewed the 2023 Health Canada Model Standard for MAID. In September 2023, we wrote to the federal ministers expressing the following concerns. The standard does not require the involvement of a psychiatrist in the assessment process for all MAID assessments for mental disorders. There is no international or accepted definition of irremediability in mental disorders and addictions. You can look at past treatments, but the most important question is what's going to happen in the future. There is no accepted operational definition to differentiate suicidal ideation and medical assistance in dying requests among people that are not dying. There are inadequate safeguards to protect vulnerable groups that are disproportionately affected by mental disorders. Due to geographic barriers, patients in underserved areas will be more likely to obtain MAID instead of evidence-based care. And international experience has clearly demonstrated MAID being used in common and treatable mental disorders and is not reserved for the very rare and refractory conditions. The Health Canada standard does not guide psychiatrists on how many treatment trials is required before recommending MAID, because there's no evidence on this particular issue. Proponents of MAID believe it is discriminatory to exclude people with mental disorders from accessing MAID, but we completely disagree with this. Equity does not mean each person gets the same treatment. Unlike physical conditions that drive MAID requests, we do not understand the biological basis of mental disorders and addictions, but know that they can resolve over time. The real discrimination and lack of equity is not providing care for people with mental disorders and addictions. Advocates of expanding MAID suggest that only a small fraction of psychiatrists need to be trained to prepare for MAID in 2024. Again, we disagree. Should MAID eligibility expand, all Canadian psychiatrists will need to grapple with how to deal with suicidal ideation in the context of mental illness. They'll need to determine when to refer for MAID versus addressing suicidal ideation with medications, treatment, and sometimes involuntary hospitalization. Repeated Canadian surveys demonstrate most psychiatrists are not in favor of MAID, and Canadian Mental Health Association and Canadian Association of Suicide Prevention are against expansion of MAID to include mental disorders.
Thank you.
Finally, we have reviewed the...
Your final statement, yes.
Finally, we have reviewed the Carter and Truchon decisions and underscored that mental disorders were not tested in these cases. After careful debate in the Quebec Assembly, the Quebec Assembly decided not to expand MAID to include mental disorders, and we strongly believe Canada should follow their lead and not expand MAID to include mental disorders. Thank you.
Thank you very much. So we'll begin with Ms. Shelby Cramp-Newman.
Thank you, and thank you, Dr. Serene, for your testimony this evening. My first question, we've heard assurances that there will be a very small number of patients who qualify for MAID for mental illness. Is that true?
It's not true at all. We have a lot of people in the community who deal with treatment-resistant depression, treatment-resistant schizophrenia, and the Health Canada standard does not require treatment. It says that you have to have some treatment, but it doesn't require treatment. And this is really a major issue. And there's lots of evidence from other countries as well that there will be more requests and completions because our laws don't prevent people from accessing MAID without going through a number of different treatments.
Perfect. Thank you. Next question. We've also heard assurances that people would only get MAID for mental illness if they've had years of unsuccessful treatments. Yet, I'm not aware of any actual safeguards that would require that. If MAID expands to sole mental illness conditions in March of 2024, is it true that only people with extensive treatment histories will qualify for MAID? Or would Canadians be able to get assisted suicide for mental illness if they have not yet had access to or tried standard treatments?
I mean, that is exactly our concern with the standard. It does not state that the person has to go through treatment. It's encouraged, but it's not necessary. And again, the idea of someone who is thought reasonably about suicide and MAID is more of a concern as far as risk of suicide than somebody who's in crisis. So some of the testimony before was around if somebody's planned it very carefully, that's not suicide, that's MAID. As a suicide researcher and a clinician, I'm much more concerned about the person who's thought about suicide for a long time and has planned it rather than someone who's in crisis. Both are at risk.
Okay, thank you for that. We've also heard reassurances that psychiatrists are trained and know how to separate suicidal ideation due to mental illness from psychiatric MAID requests, and that suicidal people will not get MAID. Do you feel that's true?
Again, it's false because there is no clear operational definition of differentiating when is this person asking for MAID and when is this person asking for suicide and when they're not dying. And internationally, this is the differentiation. If somebody is dying, then it can be considered MAID, but when they're not dying, it is considered suicide. So it's very difficult. There's no operational definition on it.
Thank you. Last year, the Association of Chairs of Psychiatry in Canada wrote to the government calling on it to delay MAID for mental illness, citing a pure lack of readiness. Among the issues cited were a lack of certainty around determining irremediability in the case of mental illness and a lack of understanding with respect to distinguishing a request for MAID from suicidality. So first question is, are we any better off now than we were a year ago when it comes to reliably determining irremediability?
No, we're not. We haven't changed from a year ago.
Okay, sadly. So are there any adequate guidelines that you're aware of on how we distinguish a MAID request from that of suicidality? And has that changed from one year to the next?
No, and we have carefully reviewed the standard. And again, to emphasize that we as psychiatrists that are, providing education and training, there is no differentiation at this point between MAID and suicide requests.
And do you feel like there's a consensus among psychiatrists to move forward with MAID for mental illness?
So there have been repeated surveys on this issue. We were one of the first to do this survey in 2017, and the majority of surveys have shown that the majority of psychiatrists are against MAID for mental illness because of all the factors that we've discussed. No evidence or guidelines around irremediability. And the idea around irremediability and what you heard in the testimony is around, well, how many trials has this person had over the last number of years? I can tell you a story of a patient that I treated.
Sorry, Doctor. Serena, it's past the 5 minutes, so just a few seconds.
Sure.
So thank you very much for that. And next we'll go to Mr. Maloney.
Thanks, Chair. Okay, Doctor, I'm going to pick up where my colleague left off. The issue from my perspective in terms of readiness is the consideration about whether it's irremediable or not. If you have 10 doctors examining a patient who has terminal lung cancer, they're all going to agree that it's not going to get better. But if you have 10 psychiatrists examining somebody with a mental disorder, you're going to have varying degrees of opinion. Do you agree with that?
Absolutely.
Yeah. And some of those opinions aren't about severity. Some of them are about whether it's curable or can get better or not, right?
Exactly.
Right. Okay. So that's the nut of it. Do you believe, doctor, that there are cases with people suffering from a mental disorder where it is irremediable? Let me rephrase that. The reason I'm asking is because the challenge is determining which ones those are. And I'm not sure we're at a stage now where there's safeguards to identify those cases where you'll get the 10 out of 10 doctors who will say it's irremediable. That's a more fair way to put it, I think?
Yeah, I have seen personally, and the story that I was going to tell was, a patient of mine that I had seen had a stroke-related OCD symptoms in her 60s. I had treated her for about 2 to 3 years with different types of medications. We had tried ECT, and over a 5-year period, we were able to get her feeling better, and she was able to actually live 10, 15 years after and only died related to COVID. So again, the science is not there. As you're saying, when you have cancer, there's a physical biology that's driving the death. In mental disorders, there is no biological factor, and this is where irremediability is impossible to define.
I think you already answered this. You've read the definition of incurable that's in the model practice standard, although we haven't seen the model practice standard. I think you've made it clear that you don't think the language in this is strong enough?
Yeah, correct.
Okay.
Absolutely.
It's language that might be strong enough to protect a doctor in a legal setting, but it's not strong enough to, close off all of the problems from a medical perspective. Is that a fair way to put it?
Exactly.
Okay. Have you looked at or taken the I think it's Module 7 of the practice standard for mental health. Have you completed it yourself?
I have registered for it to look at it in preparation for this meeting, but I have not reviewed it yet.
Okay, but you're aware of the content of it generally? Do you know what the curriculum is?
I
if
have
can put
not seen
that way?
it. Again, I have not seen the details of it.
And have you talked to other practitioners, other psychiatrists who have completed it and received their opinion on whether it's adequate or not?
In my jurisdiction in Manitoba, I'm not aware of any psychiatrists that have actually completed it. I have had one psychiatrist that is part of the medical assistance in dying team that went to the June meeting, and he was quite concerned about the lack of safety around MAID for mental disorders, and really, cases that were considered slam dunk, they should get MAID. He was quite concerned that were quite treatable, especially older adults. What I'm hearing is quite a bit of concern around this.
Okay, so you mentioned today you're speaking on behalf not only your colleague, Dr. Gagnon, is with us today, but 6 other physicians from 6 other institutions. How did your group come together? And in the event that I run out of time and you're answering that question, my final question is, can we ever be ready?
About 40 seconds.
We're part of the Association of Chairs of Psychiatry, so we're 8 chairs out of the 17 medical schools. So that's how we came together. And I don't think that right now the evidence is clear enough to guide us to be ready anytime in the near future.
Thank you, Doctor.
Very much. And next we have Monsieur Thériault for 5 minutes.
Merci.
Thank you very much, Madam Co-Chair. Dr. Sarine, you've been practicing psychiatry for how long? For how long now have you been practicing psychiatry? Could you please stop my time, Madam Chair?
Translation, or Dr. Gagnon could answer.
So you have to be on the right channel, sir, to hear the interpretation. Testing 1, 2, 3. Could you please tell the witness that there is an interpretation channel?
There's an interpretation channel on the bottom right, I believe. You can select English as your option.
In the middle of the screen.
Oh, it's in the middle of the screen.
Okay, got it.
Okay, so let's try the... So, Mr. Thériault, I will begin again.
Merci. Donc,
So my question was quite straightforward. How long have you been practicing psychiatry for, sir?
2000, I got my licensing in 2000.
D'accord.
So 23 years.
D'accord.
I see. Now, in your clinical practice for the past 23 years, have you had patients who are still with you to this day?
I've had some patients that have died of either suicide or other causes of death.
OK. Donc,
So, in your opinion, there's no disease or mental disorder that's incurable or irremediable?
So I think that mental disorders are not irremediable in the sense that recovery-oriented practice, when people have disabilities, people have depression, but there is always the desire for death waxes and wanes over time, and we work with
I'm sorry to cut you off. I'm sorry, but you haven't cared for any patients whose mental disorder was incurable and became chronic. You don't have any chronic patients under your clinical care?
Yes, I have had chronic patients.
OK. OK.
I see. And those patients had suffered to some lower degrees, some higher degrees, some committed suicide, correct?
Yes.
OK.
Understood. So how can you explain that?
So how can I explain that some people died by suicide and
Une personne qui
An individual who's looked after for a chronic disease over an extended, protracted period of time that decides to end their lives, commit suicide. Do you see that as a failure therapeutically, or do you believe that there was nothing you could do at the end of the day? And don't you, in that context, isn't it your opinion that there are patients who, rather than committing suicide, I imagine you're an excellent psychiatrist, but perhaps those patients could have opted for MAID, and knowing everything that you've had in your experience, wouldn't it have been preferable that those individuals have access to MAID rather than committing suicide after years and years and years of treatment under your care? That's quite a straightforward question.
Well, sir, every single day we admit patients to the hospital with exactly what you're describing. And so what you're pointing out, sir, is exactly what our psychiatric practice does. We every single day admit people who've had years of suffering, who then have thoughts about dying, and reach out to their psychiatrist. And
Dans certains cas,
I understand that, but final question, in some cases, Dr. Serene, don't you believe that all that psychiatry has to offer to patients who have chronic mental disorders are as palliative care forevermore, ad infinitum?
So, but I think what you're doing, sir, is that you're saying that MAID and suicide is the same thing. Isn't that correct? Because that's exactly why we're saying that every psychiatrist in the country will need to understand when somebody shows up with suicidal ideation, should we be sending them for physician-assisted death, or should we be admitting them to the hospital?
Mais l'état suicidaire est réversible.
But a suicidal state is reversible, isn't it?
I don't understand your question.
A suicidal state is reversible, is it not? So a reversible state per se shouldn't have access to MAID. It's treatable. It's when it's irreversible and it cannot be treated, and there's that level of certainty after years and years of care and therapy and good professional care.
Okay, unfortunately, time has expired, so we will go to Mr. McGregor for the next 5 minutes.
Thank you very much, Madam Co-Chair. Dr. Serene, we're in a situation here where we're not really relitigating the change in the law. That's happened, and Parliament really recently gave its voice to that. We have a very narrow focus. So, in your opening comments, I think I heard you say that you recommend an extended pause on the law coming into effect. Can you elaborate on that a bit more? What do you mean by an extended pause?
That we're not going to be ready in another year. Some of these issues are very complicated, and we do not believe that if there's a delay by 1 year, that these issues are going to be resolved around irremediability, around differentiating suicide from MAID. So that's why we're asking for an extended pause, and that's what the Quebec government has done, because they've looked at this issue very carefully and seen that there is no evidence or guidelines to say, well, this person has gone through multiple years and years of treatment is not going to recover.
Thank you. But just for practical purposes, I mean, this committee has to table a report by January 31st. Is that extended pause? Is that 2, 3 years? Like, do you have a number that you think this committee should recommend?
We would recommend indefinite pause.
An indefinite pause. Okay.
Because again, people with mental disorders in track 2, like they're still having access, but it's really around the physical health issues, right? So, but our group feels that it's an indefinite pause.
And just borrowing on your expertise, like with the patients that you deal with, of course, like someone coming in and seeking MAID for a mental disorder as a sole underlying medical condition, because their death is not reasonably foreseeable, they're going to come under the track 2 process. So there's a requirement, of course, to have like 2 professionals look at it. So if one practitioner is having difficulty, determining whether this is a legitimate request for MAID or if it's another manifestation of suicidal ideation, what do you like? Does not the requirement for another professional stepping in, does that not give you a little bit of comfort, the fact that it's going to require 2 people to arrive at the same conclusion, 2 professionals?
But it goes back to the idea that there are no clinical practice, there's no guidelines to differentiate this. So we worked, I'm not only the department head, but I'm also the shared health lead. So we worked in Manitoba with our MAID team and our college to try to come up with criteria. And the college and the MAID team said, so tell us, psychiatrists, when would you say that it's time to give MAID instead of giving people treatment? And there's no evidence to guide us on that. And, so it really is, you can have 2 opinions, but if it's not seated in evidence, then people are just deciding to provide MAID instead of treatment.
All right. Thank you very much. I think I'll leave my questions there. I'm okay.
Merci, Mr. McGregor. Merci.
Thank you, Mr. McGregor. And thank you, Dr. Sirin. The next questions will be from senators, starting with Dr. Senator Meji. 3 minutes. The floor is yours. Thank you very much, Mr. Chairperson. Dr. Sirin, I just have a quick question for you. In your opening remarks, you mentioned that were made available, there'd be a lot of unnecessary deaths. In your opinion, does the availability of MAID equal eligibility for that individual? Is that the way you perceive it?
No, that's not how I perceive it. I think the important thing to note is around suicide contagion, that once a society makes MAID available, it's a way that the population believes that it's a way to end suffering. And other jurisdictions that have had MAID available for mental disorders, not only are there deaths due to MAID, but there are also deaths related to non-MAID suicides. So, I just want to emphasize that it's not a suicide prevention mechanism. It's really a way that we are actually going to make not only suicide deaths go up, but also MAID deaths go up. And I think I just really want to emphasize that people have lots of, there's lots of untreated mental illness and addictions in our society, and we should be spending a lot more energy on trying to make sure people are getting evidence-based care rather than, focusing as much on MAID. So there have clearly been reports about people, showing up in British Columbia to the emergency department and somebody saying, have you thought about MAID? We've had, veterans that have been asked, would you rather have MAID instead of a wheelchair? We really have to be thoughtful about the unintended consequences here about making MAID available for mental disorders in Canada. And these safeguards are false reassurances. and really, we don't agree with proceeding at this point.
Do I have any time, Chair? 30 seconds, I see. Now, if I've understood correctly, you trust your colleagues, all the same, to be able to assess a risk of suicide or simply someone who is actually going to go on and commit the act of suicide. Now, if you are saying that it's already black and white, that someone who's in a suicidal crisis is not eligible for MAID, that's in black and white, and that's been repeated so many times. But those who offer MAID, that's not good medicine, is it? Is it?
Max.
Okay.
Yeah, I mean, again, I want to emphasize that I don't have any objections to MAID in itself. For physical illness or when people are dying, we're talking about MAID for mental disorders as a sole underlying condition, and there's no evidence to differentiate a MAID request from a suicide request, whether it's
Thank you, Dr. Serene. Thank you. Thank you. Senatrice Whelan, the floor is yours for 3 minutes.
Just a comment as we begin here. You've repeatedly said that there is no access or no evidence yet on access to MAID for mental illness. And I just want to state, obviously, that for the record, of course there isn't. It's not the law yet. So it's kind of hard to collect the data and the information on a practice that doesn't exist. So 2 questions to you, and I'll pose them both, and then you could answer them. Who exactly do you represent? Have you actually consulted with all of the psychiatrists in your departments or in your hospitals or universities, or as chairs have you done this? And secondly, can you give us either a legal or a medical clinical definition of suicide contagion? Is that a medical fact? Is that a legal construct? What does that mean?
Sure. So I have consulted my Department of Psychiatry last year. We did a survey. So I represent the Department of Psychiatry at the University of Manitoba and Shared Health. My colleagues are department chairs, and they're represented individually, but they are in the position of trying to take this information and implement education and training.
So how many people do you speak for exactly?
Well, I speak for 150 psychiatrists in Manitoba.
All of whom agree with your position?
The majority of them do, yes.
What would be the number?
Probably close to 120.
Sorry, out of how many psychiatrists in Manitoba?
About 150. There's more than that, actually.
Right.
I'm just talking about my department.
So maybe you could answer the other question then about whether suicide contagion is a recognized legal or clinical condition.
So the contagion effects around suicide, when there's a celebrity that dies by suicide, there's clearly been lots of evidence around it. I was part of the co-authoring the Canadian Psychiatric Association media guidelines around suicide contagion in 2008. It's been worldwide as far as suicide prevention.
No, but does it have a legal status or a clinical status? I mean, of course, we can read in the newspaper online that there are copycats, but that's different.
But in small communities, there's been clear evidence that there have been suicide contagion effects where multiple people have died, based on one person dying. So that's.
You think that would be a condition in the context of MAID?
I do believe.
Thank you, Mrs. Whelan. Last question will be asked by Dr. Ravalia. 3 minutes.
Thank you, Chair, and thank you, Dr. Serene, for your testimony. I'm just curious, you're 7 of 17 chairs who have made this statement. Have you had any dialogue with the other 10 chairs who represent the psychiatric associations and what their point of view may be?
Yeah, so today's testimony is 8 chairs out of, right now there's 16. One department doesn't have a chair. Yes, we've had lots of discussion around this issue, and there are, a variety of political reasons why the other chairs are not here, but they were part of the statement that was made last year. And the issues that we brought up last year have still not been resolved.
2 of the largest psychiatric associations in Canada, the Canadian Psychiatric Association, with approximately 2,500 members, and the Quebec Psychiatric Association, with approximately 1,200 members, have both taken the position that people with mental disorders should have the same rights as people affected by other medical conditions. Would you be able to comment on that point?
So just want to add that as CPA, when they testified 2 weeks ago, said that they have not been fully supportive of MAID. They've talked about the idea of equity, but we addressed that in our comment that equity doesn't mean equal treatment, and the majority of the surveys done have shown that the majority of psychiatrists are not in favor of MAID for mental illness.
To the 2% of psychiatrists and 2% of other clinicians, including medical doctors and nurse practitioners who have signed up, completed Module 7 of the national standards, and are now proceeding and willing to explore the issue of MAID in individuals with mental illness.
So I mean, again, there is a controversy on this issue, but what we're trying to provide here is scientific evidence around differentiating suicide from MAID and irremediability. So we don't agree with the fact that people with mental illness should have access to MAID when there are potential treatments that can help them recover.
We've heard from expert witnesses that suicidality is actually a clear exclusionary factor for individuals seeking MAID, that these assessments are intense and deep and are multifactorial and often take a significant period of time to assess. In your own practice, have you ever come across a clinical situation where you've tried absolutely everything within current base standards and were not able to provide a responsible approach to improving that individual's mental illness?
Very quick, 10 seconds.
Well, I mean, there are cases that suffer, but the idea is to sit with somebody who is depressed and hopeless and help them with their recovery.
Thank you. Ceci met fin à la période.
This puts an end to the question and answer period. I'm so sorry, Senator Martin, the floor is yours.
Merci. So, Dr. Serene, psychiatry is a very specialized field and practice, but I know that we don't have enough across the country. So the Health Canada Health Standard, I believe, does not require that the MAID assessor is a psychiatrist. What are your thoughts on that?
So again, we were very concerned about that because psychiatrists are extremely important in assessing suicidality as well as depression and other treatments. And especially even in addictions, often people have an underlying mental disorder like post-traumatic stress disorder or depression, and that can be missed. Psychiatrists are also involved in kind of second and third level treatments beyond medications. So we're very concerned. An example would be somebody that has a brain tumor. Although there are a limited number of neurosurgeons, a neurosurgeon has to make the time and effort to help assess. We strongly believe that psychiatrists have to be part of the assessment process.
Module 7, is that correct?
What's that?
You haven't seen the CAMAP Module 7, the training
I have
module?
not.
I was curious from your standpoint as a psychiatrist, what that looked like, and I'm assuming that psychiatrist specialists would have been part of the development of it, but you haven't seen that. Is it possible for me to ask Dr. Gagnon a question? And that's a simple one. Is there a consensus among Quebec psychiatrists that we are ready to move forward with MAID for mental illness?
Si ça vous convient,
Well, if you don't mind, I'll respond in French. Well, no, there's no consensus in Quebec among psychiatrists, and that is the reason the National Assembly of Quebec decided to reject a broadening of MAID for individuals with the sole underlying medical condition of mental illness. We had a debate on this. The Association of Psychiatrists of Quebec testified and weighed in, and just as Dr. Serene just said, well, that's completely correct, and this has been reiterated in Quebec. We can't head in that direction currently. We're just not ready, and that is why the National Assembly of Quebec really decided that for the time being, it's not even a question for to be on the agenda. It's too complicated. There's controversy among patients, patients' families, Quebecers, psychiatrists, politicians. It's an issue that requires a lot more thought over a lot longer period of time, and that's what Dr. Serene was referring to, an indefinite pause. It's just so complex, complicated, controversial at all levels. Thank you, Dr. Gagnon. Thanks to all the witnesses. And at the request of your co-president, co-chair, we're going to move in camera to have a brief discussion. We have a little time left just to discuss committee business very briefly.
Thank you very much, Mr. Co-Chair. I would like to move a motion that the committee order the immediate production of the CAMAP curriculum Module 7, MAID and Mental Disorders. And let me just very briefly comment, if I may, with respect to the motion that I've now moved, that we have been, as a committee, repeatedly told, trust the CAMAP curriculum, that it is robust, and that we can have the assurance that the training is of the highest quality possible. And a key question on the issue of are we ready for MAID and mental illness is the question of irremediability, being able to accurately predict irremediability, as well as distinguishing between a rational request for MAID and suicidal ideation. CAMAP was asked 3 times by myself to provide the criterion in their curriculum. They were unable to do so. They were unable to do so when Senator Martin followed up. He said it's all very complicated. It's a case-by-case basis. That is precisely what the expert panel said. It is precisely the reason why the chairs of psychiatry wrote a letter calling on the government to delay the implementation of MAID for mental illness, which would have come into effect in March of 2023. And it was very disappointing when CAMAP was asked about providing the curriculum to the committee that it was met with reluctance. Well, Mr. Co-Chair, this committee, as a standing committee, has the power to compel production of documents, and unless CAMAP rather can point to a specific provision, way of legislation that would protect them from providing this committee with that curriculum, they must do so if this committee adopts such a motion. Otherwise, they will be in contempt of Parliament. And I think, given the seriousness of the issues at hand, the degree to which this curriculum is being relied upon to justify to this committee that we're ready for MAID and mental illness, that CAMAP has an obligation to provide this committee with that curriculum. It ought not be one big secret.
Okay, thank you. Senator Wallen?
Don't think it's a secret. I think it's the workings of a professional body, so I would move an amendment to say that those documents would only be viewed in camera and not accessible to the public at large.
This is an amendment.
To your motion?
She can do it. I don't support it, but she has every right to move the motion, the amendment.
It's a process now.
Okay, so Senator Wallen has moved an amendment to the motion that it be viewed in camera and not for public consumption. Is that agreed? Do we need a recorded vote? Okay, so we'll do a recorded vote.
Can I just make a
Oh,
comment?
yes, Mr. Maloney.
I don't think we need to overly complicate this thing. I agree with Mr. Cooper, but I agree with Senator Wallen, too. I mean, I think it's important that we get access to the document to the extent there is a document or whatever it is. But if there is any, like there may very well be legitimate reasons why this isn't a public document. I don't know that there is any, but I just think we should, tread cautiously in case there is, rather than sort of forge ahead blindly.
So, Mr. Cooper, are you in agreement? Mr. Cooper?
I mean, we're all agreeing here. I just don't want to.
Have we got agreement on the amendment?
We don't
then,
want to
or
walk
was-
into something blindly. That's all.
Mr. Cooper?
Thank you, Madam Co-Chair, and I'm somewhat reluctant with the amendment put forward by Senator Wallen, but I think there seems to be agreement that at least getting the curriculum is something that would be appropriate for this committee, and in that spirit, I would accept Senator Wallen's amendment.
With that amended motion. Okay, agreed. Thank you. Okay, so is it okay for us to
On the main motion. On the main motion now.
on the main
amendment.
motion? Okay, so amendment has been adopted. On the main motion, is it agreed? Agreed.
Good.
Adopted.
Yes, I was saying this. We will turn this meeting into an in-camera meeting. The co-president asked to share some information to the as of
Regarding-
business committee. Yeah.
Yeah.
So we'll suspend temporarily just to. Yep.
Can I encourage that we just stay open?
Well, it's business. It's more like business committee. I think it's.
Can you give us some timeline? The Senate is still sitting, so we're just trying to get back to work here. What?
Yeah, it's going to take maybe 5 minutes max. And because we have. Yeah. You have to move.
Is it with regards to briefs or timelines?
Yes.
So we could probably move quickly and open if that's agreeable.
No.
There's no one online. Yeah, there's no one online. Okay.
Okay.
Agree?
All right.
Okay. Okay.
Thank you.